Test, test, test. Test, test, test. Yeah.
Okay, good morning, everyone. Um, Welcome to many colleagues and welcome to visitors from Toronto and Ontario and beyond. Um, we have a hybrid meeting today, which um, many of our attendants are online, so hopefully they can hear me. Um, and tuning in from all over the world, including as far as Australia and New Zealand, China, South Africa, um, South America. So um, really international delegates. And the Toronto Symposium has been a, a session that focuses typically on one lesion. And so we really try to go deep into um, one form of congenital heart disease. And this year, of course, it's going to be Ebstein anomaly. And I'm delighted to have some uh, experts from around the world to talk about this lesion with us today and tomorrow, and also a number of local faculty. I'd like to just start with a land acknowledgement. Um, we'd like to begin by acknowledging the land on which Sick Kids operates. For thousands of years, it's been the traditional land of the Huron-Wendat and Petun First Nations, the Seneca, and most recently the Mississaugas of the Credit River. Today, Toronto is home to Indigenous peoples from across Turtle Island. Sick Kids is committed to working towards new relationships that include First Nations, Inuit and Métis people, and is grateful for the opportunity to share this land in caring for children and their families. Um, we've got a diverse group of interprofessional group of attendees, including physicians, trainee and allied health, and as I say, it's about a 50-50 split on in person and virtual. Just a couple of housekeeping notes. Please switch off your mobile devices, or at least the sound. We are going to be recording this session, and we will be making it available online through the Congenital Heart Academy. So all of the sessions will be available on the YouTube link, but we ask that you don't make your own recordings of the sessions. And then for Wi-Fi access, you can log into the Sick Kids guest login, and the password is "be our guest," or all one word. The speakers have all acknowledged that they have no actual or potential declarations in relation to the program, or if they have a relationship, they will acknowledge this. As I say, all the talks will be also delivered to your inbox as delegates of the meeting. This is a CME accredited educational activity, and you can claim your credits by the 20th of June. And in fact, if you wish to um, do your evaluations as you go, you can just log on using this hashtag and evaluate each session as you go along. And to get your CME credits, you need to put your evaluations in. So I just wanted to bring your attention to an anniversary. Sick Kids is 150 years old this year, and we recently held a big celebration in Nathan Phillips Square. But we had our own anniversary in the Heart Center, which was the first use of prostaglandin in a patient in North America. And in fact, the action of prostaglandin on the ductus arteriosus was really elucidated by one of the scientists in this who was working in the research institute at Sick Kids, Flavio Cosciani. Um, and he worked with one of our pediatric cardiologists, Peter Ollie, to translate this into a human treatment. And they published their findings in Circulation. So it's 50 years since the development of prostaglandin. And in fact, I'm still in regular contact with Flavio Cosciani, who is an absolute wealth of knowledge about fetal and perinatal cardiovascular physiology, and is working in Pisa. Just as this is a notice about one of our upcoming educational meetings here, a course and lectures on, including hands-on sessions with about fetal cardiac screening in the fall. And we'll also be holding our regular hands-on surgical training with the use of 3D silicon models. And you're going to get a chance to see how these can be used for cardiac surgery training in an Ebstein case tomorrow. And finally, I'd just like to promote this manual of care that we've produced at Sick Kids. Hopefully a really useful resource for trainees and all of us when we're looking after patients with congenital heart disease. So without more ado, I'd like to introduce our first session, and the chair for this is going to be Dr. Lindsay Freud, who is our head of fetal cardiology and an associate professor of pediatrics at the University of Toronto. Her work focuses on the natural history of cardiac disease in utero and investigating fetal therapies. She has a lot of expertise in Ebstein anomaly and is currently leading an international registry called the FEET study. That stands for Fetal Ebstein Anomaly and Tricuspid Valve Dysplasia, to better understand fetal and neonatal therapies and outcomes.
Great. Thank you very much, Mike. So I have the honor of kicking off this symposium with a case presentation. And this case will be presented by Dr. Raj Lally, who is one of our illustrious graduating third-year cardiology fellows here at the Hospital for Sick Children, and will be commencing an electrophysiology fellowship next week. So Raj, if you want to make your way down, we also will have the opportunity. In addition, this child had a very interesting and complex medical course, and tomorrow morning we are honored to have the family here with us. And so as we're going through the talks today, think about maybe in addition to the medical questions you might want to ask of the family. Thank you, Raj.
Thanks for the introduction, and let me start. As Dr. Freud mentioned, the purpose of this is to review a recent difficult case and to hopefully provide a sense of some of the inflections in decision making. And we'll hear from the family's perspective later in the conference. No conflicts of interest. So our relationship with this family started prenatally as a referral from the East Coast for suspected congenital heart disease. Family was initially living in Newfoundland, for which the non-Canadians in the audience is on the tip of the East Coast, and so about 3,000 kilometers away. Mom was first seen here at Sick Kids at 25 plus 6 weeks gestation. It had been a healthy pregnancy up until then on ASA and progesterone. There was an initial genetic screen which had been abnormal, but amniocentesis had been done with a normal karyotype and microarray. Just a couple clips from the first fetal echocardiogram, which I'll summarize, but overall showed suspected Ebstein's anomaly of the tricuspid valve with a dilated right ventricle and RA, and overall cardiomegaly. There was severe tricuspid regurgitation. There was no antegrade flow seen across the pulmonary valve and no pulmonary insufficiency, no effusion, and overall good biventricular function. And so the summary of that first echo was, as mentioned, Ebstein's anomaly was severe TR, tricuspid valve Z score of plus 4.8. There was no antegrade pulmonary valve flow or pulmonary insufficiency with likely anatomic pulmonary atresia, hypoplastic main and branch PAs with left to right ductal flow, and cardiomegaly with a cardiac to thorax ratio of 0.74 with good function biventricularly and an RVSP around 25. There was no pericardial effusion and normal rhythm. And the mom and the family relocated to the area for close follow-up, and on in subsequent visits was noted to have developed fetal SVT and atrial flutter, which was controlled with sotalol. And she did have an fetal MRI completed later on, which showed severe lung hypoplasia. And so in discussions prenatally, there were multiple scenarios presented in terms of the postnatal options. The RV pressures on fetal echoes were initially on the lower side, but later on became a little bit more robust, around 35 to 40. And so discussions were had around possible neonatal RV exclusion versus a biventricular repair, which would include a tricuspid valve repair, RV reduction, and possibly a BTT shunt. And so induction of labor was planned at 37 weeks with initiation of prostaglandin and admission to our cardiac critical care unit. The delivery went as planned, and baby was hemodynamically stable in room air with a birth weight of 2.5 kilos. She remained in sinus rhythm off sotalol. In the first few days in our unit, there were persistent saturations above 90%. And so there was development of NEC, which was medically managed, and a mild AKI. In terms of the first postnatal echocardiogram, which was done pretty immediately post-birth, reflected the same findings that were seen prenatally. Again, can see that severe TR with an RVSP of TR jet by TR jet estimated around 29 plus rate atrial pressure. And there was confirmation of that anatomic pulmonary atresia with mildly hypoplastic branch PAs. And so the summary of her first postnatal echocardiogram was severe tricuspid valve dysplasia with a flail appearing septal leaflet and elongated anterior leaflet with severe TR. RVSP was measuring around 29 to 32. There was a right atrial area index of 1.2, so a Great Ormond Street echo score of 3, anatomic pulmonary atresia, low, normal to mildly depressed RV systolic function, and good LV function. It was decided to monitor for the first few days and to repeat the echocardiogram to see how the RVSP developed. And on repeat echocardiogram 1 week later, the RVSP was estimated around 45 to 50 plus rate atrial pressure with unchanged ventricular function. And so in cardiosurgical conference discussion, the plan at the time was made to attempt a biventricular repair with a cone procedure, RV to PA conduit placement, RV plication, and adjustable ASD, with the bailout of a Starnes procedure if the BIV repair failed. And so she underwent her biventricular repair, and the operative course itself was stable. On TEE prior to chest closure, there was noted to be mild to moderately reduced RV function, RVSP of about half systemic with mild TR, and saturations in the 80s. And so her chest was closed. Unfortunately, on arrival to the CCU, the saturations had dropped to the 60s with more moderate to severe RV systolic dysfunction, requiring medical management with INO and inotropic support. But there was ongoing severe RV failure in the first 48 hours despite maximal medical management. And so the decision was to return to the OR 48 hours later. Sternal reopening did not significantly improve her status, and a trial at ASD restriction caused decrease in her cardiac output. And so she underwent her RV exclusion with a fenestrated patch, atrial septectomy, a modified VTT shunt placement, and takedown of her RV to PA conduit. As you can see on the echo, post that Starnes procedure, there was to and fro flow across the fenestration, good LV systolic function, about moderately reduced RV systolic function. And she overall had a stable postoperative course. She did require a prolonged CCU stay due to positive pressure support requirement from her pulmonary hyperplasia, but she was able to be transferred out of the ICU about 2 months later and was discharged home from the cardiology ward less than a week after that. In follow-up, as an outpatient, there was a stable interstage period, and she underwent her BCPS with BTT shunt takedown and bilateral PA-plasty at 6 months of age, which was also uncomplicated, and she was discharged home just a couple days after that. She did require readmission to hospital a couple weeks later with a persistent right calothorax, and so was ultimately referred for a cath MRI. As you can see on the left there, the MRI showed severe lymphatic congestion extending into the bilateral hyla and right lung with loculated calothorax, pulmonary edema, and probable lymphangiectasia. The imaging showed moderate to severe PA hypoplasia with that aortogram on the right showing a significant APC flow with about 100% of the right lung supplied by APC flow and a significant portion of the left lung as well. And so this ultimately led to a decision to take down her BCPS with placement of a central shunt and PA-plasty. There was an ongoing high output calothorax postoperatively, which was not amenable to lymphatic intervention, but there was a gradual decrease in the output and she was discharged home after a couple months. Around 1.5 years of age, she was referred for a repeat cath MRI to decide on ongoing single ventricle versus biventricular management. The findings of that were complete LPA occlusion, an RV pressure of about 2/3 systemic, elevated LVEDP, but a PVRI of less than 2. She was not felt suitable for ongoing single ventricle palliation given her prior failure with the Glenn, and there was also concern regarding the uncertainty of her RV to cope with a biventricular circulation. And so she was temporized with a reduced central shunt, LPA thrombectomy, and PA-plasty, and she was discharged home several weeks later. In ongoing follow-up subsequently, there was concern for her right ventricle, which, as you can see, was not adequately decompressed and severely dilated with adverse ventricular-ventricular interactions and bronchial compression. A repeat cath MRI was done around that time, about half a year later at 2 years of age, which was overall unchanged from the previous. Her echo at that time showed stable, good LV systolic function, about moderately reduced RV systolic function. There was to and fro flow across the Starnes patch, and you could see a little bit of mild TR there with an RVSP estimated at about 77 plus right atrial pressure. So in discussion with family, the options that were presented were a Starnes takedown to biventricular circulation, a Starnes takedown to a 1.5 ventricle circulation, and a heart transplant assessment. The combination of these tests were rediscussed at 27 months of age, and the decision was to proceed with a biventricular repair with takedown of her tricuspid valve patch, placement of an RV to PA conduit, atrial septation with a 5 millimeter atrial communication, and if she remains cyanotic coming off of pump, then to consider a small central shunt. Prior to her repair, there was an interval finding of severe proximal RPA stenosis on CT, but ultimately at 34 months of age, she underwent the above surgery with PA reconstruction and a placement of a 5 millimeter central shunt, but which was able to be clipped in the OR with saturations remaining in the 90s. And as you can see from the echo clips shortly afterwards, overall a good result with mild TR, no tricuspid stenosis, and ongoing reduced right ventricular function, but good LV systolic function. And that was her last surgical procedure to date. We're now almost 2 years later, and these are the clips from her most recent echocardiogram, which shows stable, moderately reduced RV systolic function and good LV function. Her tricuspid valve is functioning well with mild to moderate TR and no stenosis. Her branch PAs are moderately hypoplastic with moderate gradients. She's now over 4 years old. She's very active, growing and developing well. She's well saturated and does not need any intervention at this point, but requires ongoing frequent surveillance. And that brings us to the end of the case. So hopefully that provides a bit of sense into the decision-making around the inflection points of her case. And we will hear from the family's perspective later on. Thanks.
Thank you very much, Raj. We have time for a question or two from either the audience or our virtual attendees. And perhaps while anybody might be thinking of a question, I just want to acknowledge that we did this case with the expert consultation of the doctors De Silva, as this was our first Starnes takedown case here at the Hospital for Sick Kids. And we've gone on to do several others, but certainly we needed your expertise to guide us through what was a very, very challenging course for this patient.
Quite a few questions raised by that case, and hopefully, I just wrote a few on my list here. How to select patients for RV exclusion, how to evaluate patients for BCPS, and how to evaluate patients to convert from single ventricle to biventricle, and also some general thoughts about pulmonary artery development and so on. But I think that the way the syllabus has been designed hopefully will now you've got some of those questions in your mind from that case that we'll be going on to tackle them in each of the sessions.
Agreed. Go ahead.
My question was there, when we do the RV exclusion surgery, normally we expect there is a regression in the size of the right ventricle. Do you think why this RV size didn't reduce because there is a potential for the ultimately conversion of the BIV, or it is very difficult to predict why the RV size didn't reduce with the RV exclusion?
Yeah, I think that's a great question. The question was, in her case, why didn't the RV decompress? And it remained quite robust, actually, with a very high pressure. I think one of the reasons, and I'd be happy to hear from some of our other experts that are here, one of the arguments that you can make for this case in particular is that it actually really ended up being a case of tricuspid valve dysplasia, where the right ventricular myocardium may have been much less affected than in a true Ebstein anomaly of the tricuspid valve, which is really a right ventricular myopathy as well. And so I don't think it was necessarily technical as much as that was, I think, what her intrinsic right ventricular myocardium was capable of. But what we often see is that in the fetuses that have been subjected to torrential tricuspid regurgitation throughout pregnancy, as you saw from some of the fetal clips, the right ventricular myocardium just becomes very deconditioned. And so sometimes the Starnes, just to give it a chance to relax, remodel, and recuperate, can then be recruited later. And certainly we'll hear more about that during this symposium. And I think that's what we saw for this particular patient, in my opinion. Dr. De Silva.
Congratulations on a very nice presentation. Excellent case that to illustrate the importance of the pulmonary vascular resistance. I think at the beginning, as a newborn, the operation didn't work, probably or certainly because the pulmonary vascular resistance was too elevated. I think an option at that time would to add a shunt. But you never know. When you do the Stern technique, is very well uh, known the result, and I think you have more chance of success. But what is important is when you have pulmonary vascular resistance, elevated pulmonary vascular resistance, you need a competent pulmonary valve. And that's what you did in this case. I think that was very important because some people would keep the valve incompetent, and that would not work in this case.
That's an excellent point about the pulmonary vascular resistance as well and what the right ventricle can handle in that neonatal period.
She also have a quite significant right ventricle dysfunction actually after the biventricular repair, and that's something that we are quite worried about. In addition to the cyanosis, so that's why we converted to single ventricle circulation.
So I think that the dysfunction of the right ventricle is related to many factors, like first the small pulmonary arteries, like Jose said, and also the opening of the right ventricle to do the RV2PA, you are opening the ventricle. And then when you detach the valve from the ventricle itself, usually we see in the immediate post-op some RV dysfunction. So all the factors combined, I think, create that situation that the kid didn't tolerate well. In this situation, what we do in Pittsburgh, if the heart is small, not wall to wall, sometimes we do a stent in the PDA alone because it's pulmonary atresia. And if the heart is too big or the patient is in critical condition on ECMO, then we do the STARS procedure immediately. Usually with the pulmonary atresia, we choose not to do the biventricular repair initially.
With ductal stenting, do you get a lot of runoff that compromises cardiac output, or what has been your experience with how these patients manage physiologically with
Yes,
ductal
so
stenting?
that's a very interesting question. Some patients, they struggle a little bit for a period of time, but then they reach a point that they can fly. But others, like the last case we did, the patient did well in the first days, but as soon as the pulmonary vascular resistance dropped more, he went on heart failure, low systemic output, and then we need to go back and do the STARS procedure. So those patients are a little bit
Tricky.
yes, tricky to manage. So we need to adapt the situation to special case.
But in this case, because the pulmonary, the right ventricular pressure was high, like 35, I expect this patient to do well with the repair. I think I would probably I would recommend what you did. But nowadays, there's a tendency to do stance from the beginning, as Luciana mentioned. But if you have a high pressure in the right ventricle, then you should try. You can do two ventricle repair, especially it's very high, like 50, 60, or 70. And sometimes they can do even the cath lab, try to open the pulmonary valve to begin with. So I think the case was well managed and very acceptable. All the steps that were done. Unfortunately, the patient has a pulmonary vascular disease, elevated pulmonary vascular resistance, which persisted. So, and the good thing is that that didn't allow to go to single ventricle because I think the patient better off the way he is now.
That's right. I think it highlights why this case was so incredibly humbling for us is because the RV pressure, we knew it was borderline, but we were optimistic. And I think it just goes to show that you can't always predict how that right ventricular myocardium is going to respond in the neonatal period with smallish PAs, high pulmonary vascular resistance. And I should acknowledge that all of this was the beautiful technical work of Dr. Hanjo, who took this patient to the operating room many, many times, as you saw, and really heroically reconstructed those branch pulmonary arteries. And you'll see the patient herself, hopefully tomorrow, and you'll see how amazing she looks. So thank you for the discussion.
Okay, we'll move straight on to the next session. It's a great pleasure for me to introduce my longtime mentor and friend, Dr. Shi Jun Yu, who is, of course, our professor of medical imaging and pediatrics at the University of Toronto, and a world expert in pediatric cardiac MRI and CT, fetal echo, 3D modeling for cardiovascular pathologies. He founded the 3D printing program here at Sick Kids in 2007. And he has been organizing the hands-on surgical training courses along with our cardiovascular surgery colleagues. Dr. Yu has published over 300 peer-reviewed scientific papers and written or co-written 5 books and 28 chapters.
Thank you, Mike. Good morning, everyone. So, okay, let me here. Okay, so we discussed a lot about the hemodynamics and functions in the context of treatment, but in congenital heart disease, still it is a structural heart disease. Hemodynamics and the all functions related to morphology. So that's why morphology is important. In the 2025, I think a cone reconstruction is standard care, and then we need to understand the morphology for this context. And then I hope my talk is for better imaging and then better surgery. Okay, I do not have any disclosure. I will talk about the normal tricuspid valve anatomy very briefly, and then talk about tricuspid valve and right ventricle in Ebstein's anomaly, and very briefly about the left ventricle in Ebstein's anomaly. Material I use in this presentation is from our Sickkids pathology specimen collection. So my pathology colleagues helped me a lot. And then previously I reviewed and re-reviewed with my 3D modeling fellow as a surgeon, Francesco Bertelli, who you're going to see later in this meeting. And I will also appreciate Dr. Norman Silverman, who shared all his slides with me for better understanding. Okay. So also that the Israel Valverde, and I reviewed 25 cases for echocardiograms and the CMR images for better understanding of this pathology. Okay, looking at the normal anatomy, this is open right ventricle. You all know this is a septal leaflet, and then you have anterior or superior leaflet and inferior or posterior leaflet. These are supported by medial papillary muscle on the septum, and then anterior papillary muscle, which is supported by moderator band usually. And then posterior papillary muscles, usually multiple and sometimes indistinct. So looking at the anterior and the posterior leaflets a little better, you can see that here, anterior papillary muscle. Let's see, okay, wait a second. Let me call up where is the cursor? Setting. What? Not showing. Okay. So for some
Pointer.
Okay, here we go. Laser point. So now you see it. Okay, here, so this is the open right ventricle again. You have anterior papillary muscle, you have anterior or superior leaflet of tricuspid valve, posterior or inferior leaflet of the tricuspid valve. What I would like to emphasize is the fact that posterior and anterior, they might be seen as a separate structure. Actually, it is a continuous structure with some connection here. It's not completely separate. Okay. So that anterior papillary muscle almost always supported by moderator band, which can be prominent, which can be very indistinct. Okay. So then we all know that normally mitral valve and tricuspid valve have offset attachment, and that is known to be less than 8 millimeter per the square meter of body surface area. However, I had a little bit trouble in using this one, and then we reviewed all normal MRIs, and then we produced the percent displacement, which is the level of displacement divided by length of left ventricle. Okay, then we find in every case that is less than 20%. Any Ebstein's anomaly we have diagnosis is more than 20% of the cases. Okay. So the definition of Ebstein, we all know that it is the apical displacement of the basal attachment or hinge of the tricuspid valve leaflets, and actually septal leaflet is the fundamental essential feature. However, we should all know the pathology is in infinite variability, causing tricuspid regurgitation with or without stenosis. I haven't seen any other pathology having this much variation. Okay. So the goal of the treatment, as we all agree, is that to make the coherent valve leaflet tissue surrounding the entire anatomical right AV junction, not the functional AV junction, anatomical AV junction. To achieve that, we need to have an understanding of tricuspid valve better. Each tricuspid valve leaflet need to look at for the basal attachment, which is hinge point, and the distal attachment, usually free edge, also the ventricular surface of the leaflet. And then also we need to look at the commissures, which is a transition between the leaflets and morphology carefully in terms of size, integrity, thickness, and mobility. And then also right ventricle need to look at how much is the atrialized ventricle and how much is functional right ventricle, and what is the nature of the myocardium. And also we need to look at tricuspid valve and pulmonary valve. Okay. Having said that, starting with the basal attachment. So we all know that septal leaflet is always displaced. That is the essential feature of diagnosis. Posterior leaflet usually displaced, not always. Okay. Anterior leaflet almost never displaced, but there are a few reports claiming that anterior leaflet is also displaced. Okay, so diagram here below, published in 1979 by Anderson et al., is very, very fundamental information. So you have here the tricuspid valve spread out, open, and then you have posterior leaflet, septal leaflet. They are displaced in this way with the maximum displacement at the crux cordis usually. Okay. Anterior leaflet not displaced. Okay. So for the looking at the septal leaflet, displacement is toward the apex, less superiorly and more inferiorly toward the crux cordis. That is all known. So this is a right AV junction in open the heart. You can see septal leaflet displacement here, posterior leaflet displacement here. As you can see, septal leaflet displacement in up is less, and the valve is better developed, and lower displacement is more. So in that context, we should be careful about what is the displacement index and percentage is, because it depends on where you image. Okay? If you go up, you underestimate. If you go down, you see the maximum displacement. But that is the 8 millimeter rule we use. That is in the middle somewhere. Okay, so in the four chamber here, we use the displacement index, which should be more than 8 millimeter per square meter of body surface area, and percentage displacement should be more than 20%. Okay, so here is the example. Same patient, you have your two echocardiograms appearing to be four chamber. But if you look at the superiorly, valve is attaching to the AV junction, while at the bottom, toward the bottom, you have a significant displacement. So in that regard, which number will be using? So that is some issues. Okay. Moving to the posterior leaflet also is displaced. Okay, usually, not always. More displacement is medially toward the crux cordis and less or no displacement laterally toward the anterior papillary muscle. Okay, so here in this MRI, you can see two cuts. The sort of two chamber view of the right ventricle. So on your left is toward the lateral aspect, and you can see posterior leaflet actually is at the AV junction, while medially at this point is significantly displaced. So displacement of posterior leaflet is not uniform. Mostly the medial is more and the laterally much less. And then there is not infrequent finding. Okay. So the other is that anterior leaflet is not, almost always not displaced. My personal experience, I have never seen anterior leaflet also is down. Okay. So in the two-chamber view, you can see there is significant displacement of the posterior and actually septal leaflet too. However, anterior leaflet is right at the AV junction. And then you see the visible anterior leaflet here. Okay. So, and then also important is that leaflet morphology in terms of size and integrity, thickness, and mobility type of thing. Septal leaflet and posterior leaflet show variable degree of hypoplasia, thickening, and dysplasia. Anterior leaflet, usually large cell-like, can be thickened and dysplastic, but very often very thin. Okay. So also important is that posterior leaflet, looked at the images in 25 cases, and then look at the specimen. Posterior leaflet, very frequently very thick, and then usually described as muscularized or sheet-like. Okay? And then, however, in contrast, the septal leaflet is less frequently, but quite the fair number of cases show muscular sheet-like thickening. And anterior leaflet actually very infrequent. In this case, actually, all three leaflets are muscularized. Okay. So looking at the leaflet morphology separately, septal leaflet, usually larger superiorly and smaller inferiorly, not always though, can be well developed, often mildly to moderately dysplastic with curled or lumpy free edges, can be very hypoplastic, vestigial, or can be totally absent, and then can be muscular or sheet-like. Okay. So here's on your left side is the MRI showing that very well developed and thin the septal leaflet of the tricuspid valve, while on the right side in pathology, it is hypoplastic and significantly dysplastic. Okay, here, another case on your left side has the hypoplastic and mildly thickened leaflet. On your right side has the more severely thickened, curled and lumpy edge. So here that from Dr. Silverman on your left. So I don't know whether we should call that as a kind of valve tissue or a kind of accessory tissue tag, but that can be seen. I have seen a few cases like that. On your right, leaflet itself is very, very deficient, almost totally absent. Okay? So also, the leaflet can be significantly muscularized like this case from Dr. Silverman. Okay? So looking at the posterior leaflet, usually smaller medially toward the septum and larger laterally toward the anterior papillary muscle. Can be well developed like this case here. Inferiorly, you see the posterior leaflet. But however, it's often mildly to moderately dysplastic like this case here. And then often muscular, at least partly, and then you don't see the free leaflet here. So a little bit up, you can be seeing that free portion, but there is significantly thickened sheet-like muscular part. Okay. And then this is all three leaflets became very sheet-like and muscular. Okay. So going to the anterior leaflet, probably you're very interested in, especially surgeons will be interested in anterior leaflet, but that is the major source of usable the leaflet for cone procedure. Usually large, and then if it is very large, we define as sail-like. And they can be redundant, and then infrequently small, and then not infrequently have fenestration like here. Okay? So this is on your left is that is sail-like the anterior leaflet fused with the posterior leaflet and then very irregularly thickened and dysplastic. I personally don't know that how good it will be for surgery, but if this is the only resource you can use for the surgery, you need to deal with, but very dysplastic. On your right is a markedly thickened and tethered to the anterior free wall and the papillary muscle. So here that example of thickened anterior leaflet. Here is a septal leaflet. There is a fenestration here near the commissure, 2 additional fenestration in the rolled up septal leaflet here. Okay. So the other is that distal attachment. The reason why it is important is that whether that attachment should be used for final surgical outcome or you need to remove all kind of things. So distal attachment can be to normal papillary muscles, to ventricular septum, to right ventricular free wall, or to abnormal muscle bundle. And then that could be through normally developed cause, short thickened cause, or direct linear or interrupted attachment. Okay. So this is the example. On your left side is the septal leaflet goes to the septum with a thickened and thawed cause. And on your right side is the echocardiogram showing from the ventricular side of the septal leaflet, you can see multiple cause going to the septum. Okay. So at the surgery, apparently you want to remove these cause one by one. Okay. And on your left side is that the thickened chordal tendinate to normally form the papillary muscle. So here you see that the thickened anterior leaflet with thick cause, and this is medial papillary muscle. This is anterior papillary muscle. You have your cause a little bit short and very thickened. Okay. On your right side is actually the anterior leaflet, posterior leaflet is continuous, and then it has a direct attachment not only to the anterior papillary muscle, to the adjacent right ventricular wall too. And then this is another thing that I want to re-emphasize. What it is that on your left side, you can see AV junction is here, and then this is right atrium, this is right ventricle, this is inferior wall of the right ventricle, and the tricuspid valve leaflet appears to be attached to here. But if you look at slowly moving video clip intentionally made in that way, the leaflet is actually delaminated from the ventricular septum, but it is attached to short cause. So so we make it simple. This is a basal attachment. These are the short caudal attachment of the leaflets to the inferior wall of the right ventricle. And then this is the even shorter attachment to the ventricular septum. In echocardiography, one may be mistaken to describe that this is the actually displaced attachment, which is not. And the reason why it is important is that easy to delaminate this and then use for the surgical reconstruction. Okay. And then another is that this the anterior posterior leaflet complex has the multiple caudal attachment to the anterior free wall of the right ventricle. Okay. So this is another case showing that making a tricuspid valve sac, and then there is a thickened leaflet or muscularized posterior leaflet, and then on your right side is an interesting imaging technique that my colleague Chris Lamb developed. What it is that in this the enhancement study, all fibrous tissue can be visualized, which means that all valve tissues and fibrosis will be shown as a white signal here. So you can see the actually tricuspid valve is continuously all the way down here, and then apparently to that muscular bundle, it is firmly attached. That's how it's not moving, and there are additional muscle bundles below that. Okay. So here is another one. The anterior leaflet of the tricuspid valve has long linear direct attachment to the free wall of the right ventricle. And in this case, on the right side, has the anterior leaflet finds another abnormal papillary muscle from the anterior wall of the right ventricle, and there is direct attachment there. So there are many, many, many different variations of leaflet morphology and the size and all of this. Okay. Another important thing I want to emphasize is commissural fusion. So normally, as I showed you already, this is the anterior papillary muscle, this is anterior superior leaflet, this is posterior medial, the inferior leaflet, and this is the kind of commissure, which is a little bit attenuated part of continuation of the leaflets. However, in this case, actually, that attenuated part is not small. It is as large as the rest of it. And then it has a short caudal attachment to the papillary muscle, which means that anterior leaflet and posterior leaflet together is a sort of monocusp. Yeah. Okay. So commissural fusion, commissures between anterior and posterior leaflets and between septal and posterior leaflets are often not definable. Fused anterior and posterior leaflets may appear to be a monocuspid valve. All leaflets can be fused to form a tricuspid valve sac, which is called the stenotic Ebstein. So this is the original Ebstein's the description. And then this is the slide I got from the Dr. Norman Silverman. It is exactly the same almost. And then you have a kind of tricuspid valve forming a kind of another cavity, which is completely concealed except for small orifice toward the outlet. And this is called the tricuspid sac. And then usually functionally it is stenotic. Okay? So this is the famous, the Ebstein malformation picture worldwide, the use. This you can see the tricuspid sac very, very well. So this is the open one of the similar pathology. Okay. So this is MRI picture of the similar, the pathology. You can see that the valve leaflets barely move and very redundant and forming a sac. And then orifice 2 is that toward the outlet here, toward the outlet here. Okay. So moving the next is the commissure deficiency. So which means that I talked about the fusion, but also anteroseptal commissure is frequently deficient. And then there is a major source of regurgitation. Okay. So this is an example of echocardiography. So you need a long axial oblique view. So you can see the two leaflets. This is actually septal leaflet. This is the anterior leaflet. And then between that, you will see color Doppler, and then seeing that the regurgitant is that very frequently, especially if there is the commissural fusions. Okay. So in describing Ebstein's anomaly, we talk about displacement and dysplasia of leaflets and thickening, etc. So also people talk about rotation. Okay. So actually, literature is inconsistent. What is that? Some people are talking about the valvar attachment plane, and some people are talking about the valvar orifice. Okay. Completely different thing. So, and then atrialize the ventricle, okay? So what is the rotation? If you think about the basal attachment hinge plane shown in normal, that is normal tricuspid valve attachment. In minor form of Ebstein's anomaly, you're gonna have a valve rotating this way, and then if it is more, this is the way how. Okay, so in that regard, so displacement of basal attachment with the rotation of valvar hinge plane makes the orientation of hinge very different. And then also important that the size and integrity of the leaflets is important to define the valvar orifice. Here in this case, so this is the valvar annular orientation, which is rotated. But however, orifice is here. So people be careful what they are talking about in the literature, whether they are talking about the plane of this or plane of that. Okay. So pretty much that almost is done. So the right ventricle, so significantly atrialized. By word, it appears to be very simple to know where is the atrialized ventricle and where is the functional ventricle. In both echocardiography and MRI, it is very difficult to define where the junction is. In many cases during the MRI practice with fellows, I need to give up the really contouring where is the atrialized, where is the functional ventricle, okay? So here that you can see that one important thing is that functional right ventricle in fundibulum is usually dilated and hyperdynamic. So which means that this is a significant part of the functional ventricle, which actually Salem-Mayer index does not take that into account. So that could be a little bit misleading in that regard, okay? So probably that this is what you want. So in the preoperative study shown here, okay, so what it is that you want to know the total right ventricular volume and then also the functional volume. But however, as I mentioned, don't trust us, the number we give you to, because it is very, very controversial. And Mike and I can have almost a 50% difference. So which means that it's inconsistent parameter. Okay. And then, but however, someone wants to know, because after surgery, you want to know how big it could be. Okay. So there are two ways of doing the contouring of atrialized right ventricle. So most of the people, both in diastole and systole, they contour the leaflet edges. However, Toronto General, Rachel Wild developed the way just to go to the annulus to annulus. So you will have a completely different number if you use one method to the other, okay? So, and then the upper one, going to the attachment site, should be appropriate for cases with freely mobile leaflets. However, that is not appropriate for poorly mobile leaflet. So therefore, what I'm suggesting is that if the really bad leaflets are not moving this way, use this way. But however, if the leaflets are moving very well, like this, and then use this way, okay? But however, there are so many cases in between, and then it's very difficult to tell which method is better, okay? So right ventricle, atrialized right ventricle can be thinned like this. In this two chamber, the view, why not moving? Okay. So here this is the AV junction. This is the attachment. There is thinned myocardium here in the atrialized ventricle. Reasonably good size, the thickness of right ventricle, quite significantly thin the ventricle here. Okay. I'm sorry that it's not moving. Okay. Finally, left ventricle. We know that septal bowing is very frequent, and especially in the stenotic Ebstein. And myocardial fibrosis of left ventricle is well known, and mitral valve prolapse dysplasia can be associated, and then myocardial non-compaction is quite common. So I don't want to talk about the significance of septal bowing. It is more the functional. Okay. Finally, you can see left myocardial, the ventricular myocardial non-compaction is seen in 25% of cases with Ebstein's malformation. Functional significance still unknown and variable in each individual cases. Okay. In summary, Ebstein's anomaly essential feature is apical displacement of basal attachment of tricuspid leaflet, especially importantly septal leaflet. And the pathology has infinite variability. You need to go for each cases very carefully. Okay? So to guide that, you need to look at the tricuspid valve in terms of basal attachment, distal attachment, and commissure, and then also leaflet morphology. And then right ventricle, you need to look at atrialized versus functional right ventricle. As I mentioned, there is significant pitfall there. And then look at the myocardium and tricuspid and pulmonary valve and other associated abnormalities. Thank you very much for your attention.
I think we have time for some questions, if anyone has questions. Sami.
Jim, it's an excellent lecture.
Oh,
Thank you for that.
And can I just remind everyone when they have questions to press their microphone light. I think yours is flashing, Lindsay, so maybe.
So one of the struggle we have is which patient have a postoperative ventricular dysfunction, right ventricular dysfunction after successful cone repair. Obviously you're world expert on the MRI. Based on the preoperative MRI, is there any way to predict who's gonna get postoperative?
Very good question. So although that I'm the long time doing the MRI and then look at the echo too, but at this time reviewing that the cases with the Francesco and Israel, I find that is really that I was not doing the practice very right, and then based on that examination, I find that we have some good idea to provide you with the better information. One way to do is that we begin to do the MRI without gap, the whole slab, and then even overlapping, and then that will allow us the four-dimensional, which means that you can manipulate any plane, and then with the time. So then I can clearly visualize what the septal leaf fluid is doing from top to bottom, and what the posterior leaf fluid is doing in the entire circumference and anterior leaf fluid. And then with rolling in and out, I think we can provide you a little bit better idea about all this, the pathologic findings I described to you. And then second one is that, as I mentioned in one case, that the so-called connective tissue imaging, we'll be able to see the leaflets reasonably well, both in systole and diastole. And then we begin to do that.
And we are going to focus on sort of functional aspects of myocardial assessment and so on in more detail in a session a bit later on. So perhaps we can revisit that important question then. In the meantime, it's really a great pleasure to have the opportunity to introduce Dr. Lisa Hornberger, who is a professor of pediatrics and an adjunct professor of obstetrics and gynecology at the University of Alberta. She is also the division head of cardiology at Stollery Children's Hospital. Dr. Hornberger is a former faculty at Sick Kids, and she has been studying Ebstein anomaly, I think, for her whole career, and in fact was recently recognized for her contributions to pediatric cardiology and echocardiography specifically in a ACE Founders Lifetime Achievement Award in 2022. So, and she is going to talk to us about the physiology of Ebstein anomaly.
I'd like to start by asking the AV folks to help me get to HDI too, so that I can present from my laptop. I'm not seeing the option here. Maybe device controls. This is really not my forte, okay? Perfect, okay, that's it. Thank you so much. Yes, this is actually one of my areas of greatest passion with respect to congenital heart disease, and I want to thank Mike and the organizers of this program within Sick Kids for having invited me to give this talk. So I have to say, and Mike had mentioned this, while I have no serious disclosures that I really have to disclose, I have to say, that Ebstein's was my first introduction to fetal cardiology through my career mentor, David Sohn. So obviously a very important memory for me, and in fact, how I met my husband. So it's a little geeky, but in fact, Ian and I met at Boston Children's Hospital on their cardiac ICU. We were both doing this rotation and started talking about Ebstein's, and we were passionate about it. We looked at each other, and that was it, okay? And 30 years later, we have these beautiful 3 daughters and a growing family with a son-in-law on the way. Anyway, so it is near and dear to my heart for that many years. And he and I had many conversations in the hospital, many conversations out of the hospital. The kids were like, time out, stop talking. Because we really cared that we needed to understand this much better. And the hard thing is it's such a rare disease that you get so few of these any one time in any one institution. It takes a long time to really understand. And the truths are, as much as the anatomy that Shujun showed is a spectrum, so too is the pathophysiology. And it can't always be predicted by the anatomy. So really, and you really have to look at every individual patient on their own with understanding their pathophysiology. Understanding the pathophysiology is absolutely critical to planning care before and after birth. So there are key contributors that include tricuspid morphology and displacement for sure, as Shijun showed. And these will influence the severity of tricuspid regurgitation, as does the RV pressure, the size of atrialized and functional RV, which certainly influences what happens, anatomical or the presence of pseudopulmonary atresia because the RV cannot generate sufficient forward flow, and the presence or absence of severe PR. Some PR helps you understand that the valve is patent. Severe PR is where they get in trouble. And of course, if there's additional structural or myocardial pathology, it could have an influence. So in mild Ebstein forms, there is mild tricuspid valve displacement, as you can see, really unexciting. And I see this and I get really, my heart doesn't go racing. Usually there's mild regurgitation of the tricuspid valve. Usually only involves that septal leaflet, and the RV in fact can generate sufficient pressures and eject with normal or near normal pulmonary blood flow. And these are babies that are going to be acyanotic at birth and can go many, many, many years without getting into any sort of trouble. So they have normal to near normal physiology. Getting onto kind of a moderate disease spectrum, and we'll talk about why I consider severe severe. They have greater displacement of the tricuspid valve, and you say, oh yeah, that's a really significant Ebstein's. They might not have a severe TR. They're more likely to have mild or moderate TR in a moderate form. They have antegrade flow through the RV outflow and duct, and that's key when we see this prenatally. I take a deep breath in, unless it's at 20 weeks, because you don't know what's going to happen over the next 20 weeks. And they usually have forward flow through the pulmonary outflow after birth. Depending on the amount of functional RV and TR, there may be more or less shunting right to left at the atrial level, and they may be cyanotic, but they're less severe usually early on if you have antegrade flow through the ductus arteriosus. These are ones we don't deliver, are in our high-risk institution necessarily because they actually can do quite well early on. But in time, there's progressive TR. There's RA and RV volume load and consequent dilation. There's a reduction in forward pulmonary blood flow or potential reduction, and there may be increasing right to left atrial level shunting with cyanosis, especially as they're becoming more active, and then a negative impact ultimately on the LV, which we're going to talk about a little bit later. And these are patients long-term that may be years, even decades out, that start really developing significant congestive heart failure symptoms and atrial tachyarrhythmias. So severe disease in and of itself is a spectrum. And I would consider severe disease that is a duct-dependent lesion at birth. And this represents really a severe spectrum. They all have cardiomegaly. So everyone says, oh my God, it's a wall-to-wall heart. I'm like, I don't really care. They all have wall-to-wall hearts. That's not important. What's important is the rest of the physiology. All of them will have inadequate or no flow through the pulmonary valve. And sometimes that's because of severely displaced leaflets. This baby had TR coming off the RV shoulder because this was all the functional RV there was. But in fact, this baby only needed the duct to be closed. This baby did not have massive TR, had more moderate TR, but you can see a very small RV outflow chamber. Others have minimally displaced leaflets. This is definitely one, the septal leaflet was displaced, but there was massive TR that was about half, that vena contracta was about half the size of the tricuspid valve annulus. The RV pressure was 6, plus the RV pressure very, very low. But these are both really kind of in that severe category. All of them will have an obligate right to left atrial level shunt. In all of them, the LV must function as a single ventricle. And there is the key to this disease, I think. And we'll talk even more, like I said, about the LV a little bit later on, but I'm going to mention a little bit here. So all of them will have retrograde duct flow prenatally. Some of them will have anatomical pulmonary atresia, which I will tell you in the absence of PR can be hard to tell. So this is a baby that everyone's like, oh, the pulmonary valve is a problem. Sometimes it's just a linear attachment to the anterior leaflet. But in fact, this baby with ductal closure had forward flow, and it just can be very difficult. Some of them have truly, this is considered functional pulmonary atresia because at the time that the duct was open, the RV pressure was, or the RV was seeing high pressures, basically systemic pressure, and the RV just couldn't generate the pressure to generate forward flow through the RV outflow as a consequence of higher pressures out at the duct. And some of them with pseudopulmonary atresia have an incompetent pulmonary valve, and if they do, they tend to have systolic and diastolic pulmonary insufficiency. This is a fetus with that exact picture, and this is what that baby looked like after. And they can get into trouble because before birth, they steal from the placenta and the system. After birth, it stills from the system. So this is not a good finding either in these babies. They get into trouble. So prenatally, they're at risk for hydrops, acute demise, arrhythmias. After birth, they're at risk for cyanosis, arrhythmias, cardiovascular compromise, and demise.
We're having an issue with the slides not projecting online.
Okay.
And we've got our AB colleague just to come and help with that. Sorry to interrupt you.
I was looking for your HDMI because I think that's where it would work.
So that's so back to Teams, HDMI 2 on here.
Okay.
So so now the share.
All right. So, and then after birth, they are at risk of cyanosis, arrhythmias, cardiovascular compromise, and demise. And this can happen in the newborn period if you're not anticipating it and planning to move with the babies. So, I'm a fetal cardiologist at heart. I have to start with a little fetal cardiology. Most of what I'm going to talk about is actually that transition, but wanted to get into this a little bit. Based on our earlier experience, and this was my first introduction to fetal cardiology. This was work I did with David Son, Charlie Kleiman, Josh Capel, and Catherine Reed. But interestingly, at the same time, Gurley, Charlene, and Lindsay were publishing their results. And if you look at our earlier experience, we had 87% suffer a fetal or neonatal demise, more so fetal demise than neonatal, but we didn't know how to manage these patients. And we asked ourselves why. Well, years later, where are we? 45%. This is work that Lindsay Freud had done and spearheading a multi-center study looking at more recent outcomes, and found 45% fetal and neonatal demise, still quite high, with almost half related to fetal loss. So we asked ourselves why, but this was many years ago, just trying to understand. And we said, this is a right heart lesion, but in the fetus, what isn't tolerated if there's biventricular pathology. And so we said, the fetal and postnatal circulation demands at least one ventricle that can eject the equivalent of combined cardiac output. And certainly in the fetus, when you're talking about that low, resistance flow coming back from the placenta that carries oxygen, they have to have low filling pressure so they get into trouble. They also have a very high lymphatic turnover, much higher than what you see postnatally. And many years ago, Noburua Inamura, who's from Osaka Medical Center and Research Institute, this is us recently in February, came to work with me while I was at Sick Kids in the fetal cardiology program. And we wanted to look at left heart function, and we demonstrated that LV Tayanix was clearly abnormal in fetuses with intrauterine demise, with the development of hydrops with larger CT ratio, as well as pulmonary insufficiency and pulmonary atresia. So these were clearly high-risk babies, and they had abnormal left heart function. This is a really crude measure of left heart function, but it gave us some information that was telling of what was going on. And then years later, Lindsay's also shown this in a much larger cohort that from multiple centers, showing particularly in the third trimester, but I'll show you that it's already in the second trimester as well, that a big heart, increased CTA, low velocity tricuspid valve jet, tricuspid insufficiency jet, absence of antegrade pulmonary flow, and qualitatively depressed LV function were important predictors of worse outcome. So what is it about? So we really wanted to understand, what is tolerated, what isn't tolerated, and how the heart adapts in a healthy situation and an unhealthy situation. As I said, in severe Ebstein's, you have retrograde ductal flow. That LV has to take everything, the combined cardiac preload, and inject the equivalent of a combined cardiac output. The single ventricle has to do that, the other single ventricles. And we said, well, how does the healthy single ventricle adapt? Hard to believe an RV is a healthy single ventricle on HLHS, but that's what, they don't get into trouble in utero. It's very, very unusual. It's less than 5% as opposed to what we were showing you for Ebstein's. And we showed that both the single RV and LV, functional single RV and LV, develop increasing short axis diameter, become more spherical, without a similar augmentation of their apex or their length. They demonstrate increasing short axis, this is a hypoplast dimension, and in hypoplast, the RV starts to have reduced long axis function. And if you go to look at what the mechanics are of the LV versus the LV has a dynamic short axis function and functions much less off its longitudinal axis. In contrast, an RV functions off its longitudinal axis and less so off its short axis. This single RV is trying to function or is remodeling in a way that allows it to augment its short axis function like an LV. And then we showed augmented filling in atrial systole. So the atria are also important here. So we looked at Ebstein's. This is work that Luke Eckersley did as a fellow with us, and he's now pursued this further, as we'll show you some of his data. We looked at normals, the pulmonary atresia intact septum with a healthy LV, and we looked at the Ebstein's patients prenatally and then eventually postnatally. We showed the sphericity was quite comparable between controls and the single LV, or the functional single LV of the Ebstein's, versus the pulmonary atresia intact septum, where they get increasing diameters, as you can see here. Eccentricity, on the other hand, was quite increased, of course, in the Ebstein. So you have this very abnormal shape, geometry of the LV that's already existent prenatally in severe disease. We then looked at longitudinal and circumferential function, showed normal longitudinal deformation, so normal long axis function, but their global circumferential deformation, or their short axis function, was actually very abnormal. Very different than the healthy single ventricle, the RV and the LV of the hypoplast and the pulmonary atresia intact septum. And we showed that this was true in the second trimester for those that had retrograde ductal flow, a little bit less so in those that had antegrade flow amongst the Ebsteins, and very different than what you saw for the pulmonary atresia intact ventricular septum. And again, it persists in the third trimester. And then we showed that, in fact, you have low output in many of these babies, both in the second and in the third trimester, certainly relative to what we saw in controls. They had low combined cardiac output entirely coming from that left ventricle. So Luke went further because we were looking at these tracings going, God, they look horrible. So you look at the pulmonary atresia intact septum, the LV is very coordinated, synchronous, right? Look at the chaotic dance of your Ebsteins. This is terrible synchrony. And in fact, we used a novel dysynchrony index that Luke had generated, as well as a time to peak strain deviation. And you can see that they have a propensity to have significant dysynchrony, especially certain of the lesions. And this was all of our all-comers, and we'll show you how bad it can be, particularly among those with retrograde ductal flow. We also looked at atrial function. The right atrium in a fetus, postnatally as well, but the right atrium in a fetus is the conduit between your systemic venous return, but also your placental venous return, which is carrying oxygen. It has to get in Ebstein's that flow into the LV. So it has to be functioning. It's not just a passive conduit. And we said, well, what if that huge atrium, like a big baggy dilated ventricle, what if it has lost its Frank-Starling mechanism and it falls off that? Or what if the atrialized RV is causing trouble as well? So we looked at emptying fraction, fractional area change, filling rates, and emptying rates. They were all abnormal for the Ebstein's patient and much more closer to normal in those with left heart obstruction and basically a functional single left ventricle. So in fact, they also have reduced right atrial function, and maybe this is also a player in the difficulty in redistributing to that left heart to maintain the equivalent of a combined cardiac output. This was Lisa Howley's work as a fellow. So what we propose is that your RV volume load septal distortion contributes to LV dysynchrony and decreased LV function, decreased LV filling and ejection, that your dilated RA and atrialized RV also contribute to right atrial dysfunction, doing the same, decreased filling and ejection of the single left ventricle. This leads to reduced cardiac output and limited reserve, increasing central venous pressure, because if you have one healthy functioning ventricle, we learned that long time ago with cardiomyopathies and other conditions that they can survive and they don't develop hydrops, but with increasing CVP, you see hydrops. And then the PR definitely is a player in it. One, it's more severe. They can have fetal hypoxia, and it can also contribute to both decreased output and increasing central venous pressure, and you got a baby who demises, okay, or is at risk for that, or is very tenuous. Okay, now we're going to deliver this kid in this situation. So think about it. Think what you're going to do to this kid. So the right heart, we're focused on the right heart because it's the right heart lesion. Patent RV outflow and duct. Even when there's RV outflow obstruction, especially with patency though, you've acutely disrupted a low placental resistance. So you've acutely given the right heart increased afterload. What does it do? It contributes to more TR with or without pulmonary insufficiency of the valves if the pulmonary valve is incompetent, necessitating more right to left atrial level shunting. It's the way it has to go, right? And of course, if there's outflow obstruction, that doesn't help them. RV volume load, neutralized RV, guess what? Worsens that LV. It makes it harder, affects that geometry and function of the LV. And of course, if there's pulmonary insufficiency, it adds yet another layer of a badness, and that is steal from the system. So that's not good, and increasing volume load. But the left heart's also affected. So now you have a left heart that's already having a difficulty to maintain the equivalent of combined cardiac output. It's suddenly seeing a high afterload because you've disrupted the placenta. It must sustain the systemic and pulmonary circulations. So guess what? With decreasing pulmonary vascular resistance, and especially if we're using pulmonary vasodilators in the delivery room, which is a bad thing, I think, you have increasing pulmonary venous return. What does that do? It forces the LV to do even more. Okay, it increases your LA pressure as well, and the LV probably can't do more. It's already not doing very well before you disrupt the placental circuit and before you ask it to take on the pulmonary vascular bed. So it leads to increasing LA pressure, and what I consider, and it affects your obligate right to left atrial shunt. I call that a physiologic restriction of the atrial septum. It's not a problem with the atrial septum, it's a problem with those pressures. And now you have increasing central venous pressure, and guess what? It's a kid who's circling the drain with low cardiac output, increasing central venous pressure, and a baby who's going to become hydropic. We've seen that prenatally, you see that postnatally. Ascites, they get peripheral edema, and they're very, very unwell. So what can you do about it? This is actually work that that Rachel Wall did as a fellow. It's one of the few papers that Ian and I have written together over many years. I don't know why, but this was one that we had many, many conversations. And this was the first baby that we thought about getting rid of the duct. And that's because the baby had an RV pressure that was near systemic, but was developing hydrops, developing ascites, getting peripheral edema, was extremely labile. We stopped the prostans. Everyone was a bit freaked out about that because at the time we said they all need prostans. We stopped the prostans so the duct wouldn't close. Ian did ask some of the other cath folks whether they would be willing to build and occlude the duct. They said, no way. So Ian took the kid to the cath lab, and literally this was the tracing from this kid. We started with PA and systemic pressures that were quite comparable. And as soon as the duct was balloon occluded, you saw the aortic pressure go up, the pulmonary pressure go down. Everyone waited, and the stats were stable. The kid was more stable. We eventually convinced the surgeons to ligate the duct. Even then, it was really hard because it just went against the grain. And so we said, hey, look, if the RV can eject, then and you can get down the PVR after the duct starts to close, then you may actually have a baby who survives. So we started this process that if the RVSP was sufficient, we didn't know what sufficient meant. Necessarily, it had to be enough to be able to eject. And the RV outflow was patent, although we'll let the duct close to tell us whether it's patent, either spontaneously or by intervention. Then we let it play out. And until ductal closure, do everything to balance your pulmonary systemic circulation. Don't overventilate. A SAT of 92%, a SAT of 87%, even a SAT of 80% if you have a low mixed venous may be bad. It may still be a kid who's got pulmonary overcirculation and a left heart that really struggles. Don't use pulmonary vasodilators. Keep those systemic blood pressures low normal. Don't drive pulmonary blood flow. Keep your heart rates within a normal range. You can imagine LV that is struggling now is struggling at a faster rate. They don't have time to fill. So that can't help either. Support the LV function, and with ductal closure, do everything you can to reduce the pulmonary vascular resistance, but only then. And it led to a 90% survival in the experience here in Toronto. And finally, this is to tantalize you for the discussion on LV function. This is what Luke and I, and Yozo Teramachi was a fellow with us from Kurume, showed that, in fact, synchrony has to be a player in this. LV function has to be a player in this. And what we found was worse asynchrony, particularly in those with no antegrade flow. This is, again, your functional single LV. Worse asynchrony is associated with worse survival, basically no matter what we did. So this is something really important and needs to be further sussed out with a multi-center study. So in summary, as is true of the anatomy, the pathophysiology is a broad spectrum. And it's, again, not always determined by anatomic features. You really have to look at every individual patient. Pathophysiology is impacted by competency and degree of displacement of the valve, the tricuspid valve, which when severe leads to reduced pulmonary blood flow. Contributes to right to left atrial shunting that eventually becomes an obligate shunt if you don't have egress through the RV outflow. Right atrial and RV volume load, increasing central venous pressure, and to critical changes in LV function. Added severe PR contributes to a circular shunt that steals certainly from the system postnatally and from the system and the placenta prenatally when it's severe. And the pathophysiology of more severe Ebstein's worsens with the transition. So don't think you're going to get this kid out and suddenly have this kid look wonderful. You are actually making the kid sicker unless you have a game plan to change that physiology. Understanding of the pathophysiology is absolutely key to a successful care of the Ebstein's patient. And I want to thank my colleagues and certainly fellows through the years who have contributed to this work. Thank you.
Thank you very much, Lisa. That was fantastic. And apologies again to for those online. Of course, you will be receiving Lisa's slides, so hopefully you can look at those first few that weren't shown. We do have time for some questions, if there are any from the audience. Maybe I can start with one. That was a somewhat postgraduate description of some of the physiology, I would say. I was wondering, for perhaps folks who are, at an earlier stage in looking after these patients and learning about them, could you explain to us exactly what you mean by a circular shunt?
Oh, sure. I mean, when you have pulmonary insufficiency, and you're basically having flow come back into the right ventricle. And especially in the context, this is now with an open duct and you've got high flow that comes back around by TR. It's being forced across the atrial septum because you got to put that volume somewhere, comes back through the duct. And so you have the circular shunt. It also, sometimes we see it in other conditions, but there's the badness of it is it's a waste of energy for the system and the heart. It adds volume and forces more flow that has to go from right to left across the atrial septum, which is a problem. Like I said, if you also have at the same time increasing alloy pressures from increasing pulmonary blood flow, and then it also steals from the system in this context, or fetally from the placenta. Yeah, hopefully that's helpful.
Thank you. Any other questions from the audience?
Hi, Lisa, thanks. I was fascinated by what you said about the contribution or lack of contribution of the RA in the dilated state. Then thought about the RA. Do you think that's mitigated to any extent by the degree of atrialization of the RV?
You mean function? No, I think it's worsened. That probably doesn't help. But it's also this, a lot of them are huge, boggy right atria. You can imagine they don't have great squeeze. And certainly for most major pathology, especially that influences the function in fetal life and postnatally, you have to have good atrial function. That's why we get sick when we're older adults and you get restrictive physiology and atrial fib. They don't like it, right? In the very, very, very early fetus, the fetal circulation is driven by healthy atrial function. And these kids, I think that's part of that picture as well. And we're just looking at it postnatally. The hard part is we don't always get the whole of the atrium in our imaging. And I think it may require more CMR, smart CMR imagers to further kind of understand the contribution of right atrial function in this disease, but it's got to be a player.
Thanks.
Okay, well, thank you very much. I think we've got time for a coffee break now. We're going to return at 9:25. We're going to come back to some of these issues introduced by Lisa, talking about fetal management and then neonatal management. So thank you very much.
Problem is, I gotta resave it now.
Yeah. Off.
Okay, it's fine.
Yeah, I don't know.
What's that? That's new.
There's not really any way. There's a light sensor, like I said, up here somewhere.
Okay, welcome back, everyone. We'll get started. So I'm really looking forward to this next session where we'll be hearing from two of our Sick Kids faculty who are not only commanding medical experts, but also very strong leaders within our Heart Center. The first you've already heard from this morning, so I won't introduce her again, Dr. Lindsay Freud. She's our section head of fetal cardiology here at Sick Kids. We're looking forward to hearing more from her.
Great, thank you, Koyal. So my lecture is hopefully going to be a nice continuation of some of the anatomy, but mostly the pathophysiology that you just heard Dr. Hornberger describe before the break. And I've had the fortunate experience of knowing Dr. Hornberger over years, just attending conferences, and she has also really informed a lot of my understanding of how we manage Ebstein anomaly. And I'll just talk about why I'm including tricuspid valve dysplasia in a moment, and about how we manage this in the fetal period. And I'm not going to really go into this because we already heard Shijun's beautiful presentation with all of those pathologic specimens, except to say that there's one word that both of us have in our presentations, which is that there's essentially infinite variations of tricuspid valve morphology in this spectrum of diseases. And one of the other things that can be particularly tricky in the fetus, and I was actually just asking Dr. Yu about this in the break, is that what's interesting is that even in tricuspid valve dysplasia, where technically the septal leaflet is not displaced, it is so incredibly dysplastic. And in Ebstein's, where you also have dysplasia, discerning whether or not there's displacement can be very challenging, particularly in fetal life. And ultimately, in the fetus, so what I have here on the left is perhaps a more classic Ebstein anomaly, and on the right, perhaps a more classic example of tricuspid valve dysplasia as we look at these valves by fetal echocardiogram. But one of the reasons why we group them together is I think it can be difficult to always discretely determine which is which morphologically prenatally, but also that at the end of the day, the pathophysiology is the same, which is that they have severe tricuspid regurgitation, which is very poorly tolerated in the fetal circulation, where the right ventricle needs to be the driver of the work. And just to echo a little bit about what Lisa already showed us, I've got her paper here, but in the 1990s, as fetal echocardiography was really coming to fruition, there were lots of papers that started detailing just how sick these fetuses can be, including in the neonatal period. And this included many single center studies from the 90s to the 2000s to the early 2010s. And with the help of my mentor at Boston Children's, Wayne Turetsky, we were able to say, well, all of these single center studies are wonderful, but let's try to really get together a large cohort of this relatively rare disease so that we can better understand outcomes in the current era, as well as delineate independent predictors of either fetal demise or neonatal mortality. And so what we were able to do was pull together almost 250 fetuses from 23 centers. And I'm going to start a little bit by sharing what some of the outcomes are. And Dr. Hornberger already mentioned that mortality was better in our series, but still quite high. And what a lot of us look at when we look at the neonatal mortality is that you see that 1 out of 3 patients did not survive to hospital discharge. And that has served as a basis for some of our subsequent work and some of what we're going to be discussing today. But I think unique to my talk, and Lisa also mentioned this, which is so important, that up to almost 20% of these fetuses will actually die in utero. So there's a lot of work for us to do, even in the prenatal setting, in order to get these babies along and to ideally get them to be delivered close to term. So when we combine, when we think that almost 20% will suffer from a fetal demise and another 1/3 will not make it to live birth, and we exclude terminations, we come to 45% perinatal mortality, which, even though it was better than Lisa and David San's first publications back in the 90s, is still one of the highest mortalities that we have of any congenital heart disease that we care for, and therefore of great interest to those of us that are fetal cardiologists, but to all of us in the Heart Center, and underscores the reason for this symposium. When I give talks about Ebstein's, I often like to start with a slide like this, because what most people in congenital heart centers, the first time that they're introduced to the baby with severe Ebstein's or tricuspid valve dysplasia is at this moment. They have the chest x-ray with the wall-to-wall heart, they have the neonatal echo with the torrential tricuspid regurgitation, and then all of the discussions start. But I'm going to remind everyone that particularly for this disease, where we've got lots of babies that don't even make it to birth, the management really begins at the time of prenatal diagnosis. I specifically chose this clip because I think it's fairly obvious that in addition to a severe Ebstein's, this patient is also in alternating SVT and atrial flutter. And of course, is not going to make it very long. You can actually already see that there's a small pericardial effusion here until we aggressively treat the arrhythmias. And so for this disease, there's a lot that is going to be done prenatally in order to be able to give us a baby that is close to term that we can then manage safely. And so some of the questions as fetal cardiologists that we start to ask at the time of diagnosis, is antiarrhythmia therapy warranted? Obviously, that's yes in this case. What about novel fetal therapy, which I'll be discussing a bit? And what are other strategies that we can do to get this baby to term or as close as possible, working in conjunction with our high-risk obstetrical colleagues? And then as delivery approaches, as Lisa highlighted, you already have very tenuous pathophysiology, and then you have delivery, where everything gets potentially worse. So thinking very carefully about who needs to be in the delivery room. Do you need to have an OR on standby with your cardiac surgeons and anesthesia teams available? So there's lots to think about for the management of these patients, and really multidisciplinary planning for these patients is essential in late gestation. So going back a little bit to our work and just highlighting some of what we identified as important independent predictors of either fetal demise or neonatal death in both our original paper and in an important ancillary study by Sue Wang, is that first of all, we always know that more severe disease is diagnosed earlier. So those that were diagnosed before gestational age of 32 weeks tended to have higher mortality. Larger tricuspid valve annulus Z-score isn't terribly surprising, since the bigger the heart, the greater the tricuspid regurgitation, and then that becomes a vicious cycle. And in fact, can be a surrogate for CTA ratio or the Seligmeyer or GHOST score postnatally, which are all really getting at much of the same thing. And then pulmonary regurgitation. And this was mentioned a bit again in Lisa's talk, and I'm going to circle back to that because I think it's one of the few aspects of the pathophysiology that we can try to mitigate. A pericardial effusion will develop as signs of evolving hydrops, and then we're going to talk a little bit, probably more than many of you may have heard about, fetal Dopplers during this. And it's so important because for the fetal cardiologist, we don't have the patient in front of us to get their heart rate, to get their respiratory rate, to look at their skin color and perfusion and capillary refill. So what do we have to look at their perfusion is really our extracardiac Dopplers. How much blood is going in and out of the umbilical, venous, and arterial system, and of course to the brain through the middle cerebral artery. So we have to be looking very carefully at those indices. And Lisa already showed very nice echo clips of each of these. And in many ways, our talks align because she started by going through more mild to moderate and then severe pathophysiology. And I'm going to basically be doing the same thing. Except that I have cartoons instead of echo clips. And so what you can see here is a diagram where even in the face of severe tricuspid regurgitation, sometimes, you'll still have antegrade flow across the pulmonary valve and across the ductus arteriosus. And that's just maintenance of usual fetal circulatory physiology. And those patients are expected to do well in general during pregnancy and after birth. We, of course, monitor them if they're diagnosed early because things can certainly change and evolve. But those are patients that none of us really get excited about. Then there's about 20% of patients with Ebstein's or tricuspid valve dysplasia that have fixed anatomic right ventricular outflow tract obstruction. And in these situations, we see intrauterine reversal of ductal flow left to right. But in this case, that's a normal compensatory physiologic phenomenon in order to perfuse the pulmonary vascular bed in utero. And of course, those patients as neonates will need a mechanism to secure pulmonary blood flow postnatally. But the ones that we worry about the most are the ones that don't appear to have fixed or anatomic right ventricular outflow tract obstruction, but yet have left to right shunting or reversal of normal intrauterine shunting at the ductus arteriosus level. Because what this tells us is that there is so much insufficiency across the tricuspid valve and or the beginning of right ventricular failure that there simply is not enough forward ejection across the pulmonary valve. And when things start getting really bad is when you have what I call the final insult, which is pulmonary regurgitation, and that completes circular shunting physiology, or as Norman Silverman calls it, the circle of death. And this is when the situation becomes really dire. And I know Lisa addressed this in the question, but you have severe tricuspid regurgitation here with not a lot of antegrade flow. And as Lisa mentioned, you have almost an obligate right to left shunt across the foramen ovale, which of course you always do in fetal, but it's really the majority of the cardiac output. And then as that goes through the left ventricle, out the aorta, it comes back down the duct, back down through the pulmonary artery. And then because the right ventricle is often failed in these settings and it generates very low pressure, even though the systolic function may be preserved, it just goes backwards. And what you're doing is not only causing volume loading of that heart, you're actually bypassing both the systemic and pulmonary capillary bed. So after birth, you're not manifesting oxygen exchange and you're not getting cardiac output out to the body. And we look for some of these signs in utero, again, by looking at our Doppler signals. This is this is actually not a normal umbilical artery where you're already seeing that there's diminished flow in end diastole. And as the systemic steal continues to go back to that heart and that circular shunt, you can get this reversed end diastolic flow, which is a very ominous marker about your systemic perfusion. So let's walk through a case of how such a case may manifest and what we can potentially do about it. So here's a fetal echo of a patient at 31 and 6 weeks, and we can have our usual debates about whether this is more of an Ebstein's or more of a tricuspid valve dysplasia, because one could argue that the septal leaflet here doesn't look all that displaced, but it has some other characteristic appearances, particularly this anterior sail-like leaflet, that would suggest it's more of an Ebstein's. And as anticipated, you see that there's right atrial enlargement already, so there's severe tricuspid regurgitation. And when you go and you Doppler that TR jet, which is so important to understand what that right ventricle is capable of, you see that it's generating very, very little pressure. And so whether that's an intrinsic myopathy or it's getting weakened from torrential TR throughout gestation, either way, it's a failing right ventricle. And so then you see that you've got a large duct with all retrograde flow in order to perfuse that fetal pulmonary vascular bed. And it's a nice open duct with retrograde flow during diastole and systole. And so, of course, you can probably imagine that this is a patient that you're watching for closely, and you also really need to understand what's happening at the level of the pulmonary valve. Well, here you can see that there's severe pulmonary regurgitation, and it happens continuously in systole and diastole. And so that's going to tell you that you're worried here about a significant circular shunt. And I sort of already gave the warning, if you will, that I love talking about extracardiac Dopplers in the fetus in general and can't underscore how important they are. And they become even more important when you're trying to manage and understand critical pathophysiology and dynamic pathophysiology that may progress over the course of gestation. So it's imperative that we look at the perfusion to the brain by the middle cerebral artery Dopplers. We look at the ductus venosus, which tells us a little bit indirectly about what's happening in the right atrium, right atrial pressure, CVP. And then the umbilical artery and veins are also allowing us to understand what kind of flow is going in and out of the placenta. And so when we did an ancillary study to the original cohort, not surprisingly, we found that abnormal Doppler signals were significantly associated with perinatal mortality. And the one that it was almost tenfold associated with mortality is when you have absent or reversed diastolic flow in the umbilical artery, which is suggestive and highly correlated with severe PR and systemic steal, causing low cardiac output in the fetus. And of course, Lisa already went through this very eloquently, and we have a whole lecture later, which is dedicated to talking about the left ventricle and Ebstein's anomaly. But just to highlight this work that she already spoke about, but as you have these aberrations with circular shunting, the septal configuration changes, and the left ventricle in particular is not able to really contract, as they've shown with radial strain, very poor radial strain, even in the setting of preserved longitudinal strain, an incredible amount of dyssynchrony and adverse ventricular-ventricular interactions between that volume overloaded failing RV and the LV that is trying to maintain all of the systemic circulation with adequate stroke volume. And so that certainly is just one other insult to injury that exacerbates poor cardiac output in this population. So when we look at this, when we go back to look at this particular fetus and examine how all of these factors are influencing the Dopplers, we see that the ductus venosus here has got this A-wave reversal. So that's suggestive of very high right atrial pressures and central venous pressures in this particular baby. The umbilical artery looks awful. This is very concerning when you have the diastolic flow reversal, suggestive of your systemic steal. In the brain, you also have almost absent end diastolic flow. And then the umbilical vein has notching, which is often considered a pre-terminal sign in a fetus. It's highly correlated with fetal acidosis and demise. So we've got a very, very, very challenging situation and a fetus that's only at 31 and 6 weeks. Now, here at Sick Kids, we have the tremendous ability to also be able to do fetal cardiac MRI in these patients, thanks to Mike Seed and his team. And we try to do fetal cardiac MRI actually as much as possible in these patients, particularly in late gestation to understand their hemodynamics. And earlier, we will also do it sometimes for a lung assessment to try and understand how the cardiomegaly is impairing lung development. But in this particular case, what I wanted to show by looking at fetal cardiac MRI is that in having looked at many of these patients, we've been able to draw these diagrams. We look at cardiac flows in Ebstein anomaly, both without and with a circular shunt. And the numbers to really call your attention to is your cardiac output that's manifested here by your numbers in the descending aorta. So you've got about half the systemic perfusion. And in addition, you also have about half of the cardiac output going to the brain when you look at your SVC flow. And so these patients really are suffering from poor cardiac output throughout the fetal body. And so given this state and our concern about fetal survival, there was raised the notion that we normally tell pregnant women to not take NSAIDs because we know that it causes constriction of the ductus arteriosus. But in this particular lesion, the ductus arteriosus is actually a very dangerous and vicious part of the cycle. And some of this idea, by the way, it was really lifted off of that paper that was shown by Rachel Wald and Lisa Hornberger, where they talked about limiting ductal patency in the neonate. So the thought emerged, well, why don't we try to do that in the fetus if the duct is really a prominent part of the pathophysiology. Can we interrupt this circle of death? And just like any other fetal therapy, it doesn't occur in a vacuum, certainly not a cure. But the idea is that if you were to be able to obtain some ductal constriction, then you can improve the fetal hemodynamics as we follow those extracardiac Dopplers. We can limp this child, this fetus along to get to a live birth closer to term, thereby improving survival. As we all know, gestational age and birth weight are very important for our congenital heart surgery outcomes. And then maybe even these patients would have improved neurodevelopment, which is a concept I'll return to in a moment. So just as a proof of concept, in this particular patient, she was administered NSAIDs, so she takes them orally. They pass transplacentally to affect fetal ductal constriction. And then you can see that the duct is now really beautifully constricted just a couple of days later. But the most remarkable thing is how those Dopplers normalize. So you have better cardiac output and lower central venous pressures. And so here you can see that there's normalization of the ductus venosus. You have restoration of antegrade diastolic flow in the umbilical artery, as well as in the middle cerebral artery. And it looks like I didn't include it, but you had normalization as well. You can see it here of the umbilical venous Doppler. So all very, very encouraging findings. And so again, together with my mentor, Dr. Turetsky, over a course of 10 years or so, we had been treating patients with NSAIDs and got the group together to look at a case series of really how effective is NSAIDs in causing ductal constriction and affecting the survival to live birth and the gestational age at birth in this cohort. So we had 21 mothers at 10 centers who were offered therapy at a median gestational age of 30 weeks. And we found that nearly all had improvement in their degree of pulmonary regurgitation, as well as normalization of their extracardiac Doppler patterns. When we look at the flow chart, we see that, first of all, there were some women that declined. So, of course, they have their natural history outcomes. And then of those that consented, it's important to note that we can't achieve ductal constriction for whatever reason in all patients. And so we saw that about 20% of them did not achieve ductal constriction. But when you look at those that achieved ductal constriction versus those that either declined or did not achieve constriction, we saw that there was a significant difference in survival to live birth. And very importantly, as we'll hear in the next talk when we discuss neonatal management, you have a much more mature neonate at 36 weeks versus 33 weeks, which really can make a world of difference in the care of this fragile neonatal population. This was also shown by fetal cardiac MRI. And so with the volume across the circular shunt drastically reduced from 42 to 10% of the cardiac output, you see that all of a sudden you have dramatic improvements in flow in your SVC for your cerebral perfusion and your systemic perfusion with increased flow in the descending aorta. And to go one step further, remember that now that we get more antegrade perfusion into the middle cerebral artery by constricting the duct, does that ultimately correlate with anything notable in terms of the baby's brain? Well, again, Mike Seed and his colleagues in this work showed that, in fact, when they looked at fetal brain weights, when you look at controls versus those without a circular shunt versus those with a circular shunt, those with a circular shunt had the lowest fetal brain weight, which we now are coming to understand can be associated with neurodevelopmental delays in the long term. So by constricting the ductus arteriosus, in addition to enabling a live gestation closer to term and allowing for survival, we're also significantly improving brain perfusion that may translate to better neurodevelopmental outcomes over time. Remains to be seen, of course, but very interesting to think about. The other thing that we found in looking at the follow-up of the fetal cohort is that when we look at gestational age at birth and survival to neonatal hospital discharge, we found that 37 weeks, more or less, was a pretty critical cutoff, such that infants born less than 37 weeks had a 4-fold incidence of mortality compared to those born at greater than 37 weeks. And so while we often are wanting our fetuses with congenital heart disease to get to full term, 39 weeks, we understand that these fetuses are sicker, and we try to see how much we can get them along to at least 37 weeks. Now, I want to talk a little bit more about the neonatal follow-up of this fetal cohort, because I think it will set the stage for further discussions in the symposium, and also just to highlight that very, very tenuous transition period for this fragile group of fetuses as they transition. And Lisa pointed this out as well. In that cohort of patients, we had 7% of the population that didn't survive 24 hours. So that's an incredible period of risk for these patients. And then we have the additional 25% that died at some point prior to hospital discharge. In terms of risk factors for neonatal mortality, it's all of the fetal risk factors that we discussed, plus lower birth weight, not surprising, and lower right ventricular pressure as measured by TR jet velocity. And I think this will be a common theme, since it's one of the relatively easier ways for us to assess what the right ventricle is capable of. And just to show a figure from here, there was a correlation here between lower TR jet velocity and death versus palliation versus those with the highest TR jet velocity were most likely to survive with a biventricular circulation at the outset from the neonatal period. And again, this is more, this will be discussed. We've got many surgical experts speaking to us during the course of this symposium, so I won't belabor this, except to say that when you look at mortality, which is denoted in purple, relative to survival as denoted in blue, the safest way to get some of these sickest fetuses out of the hospital alive is to do the right ventricular exclusion, or Starnes procedure, which had 0% mortality. And this was published in the appendix to our original circulation paper. And I have to admit, I don't share this slide often, but it is very interesting to look at every once in a while, because what it shows is that contrary to a lot of our congenital heart surgery literature where volume and mortality are highly correlated, there's not much of a correlation here. And part of that is because Ebstein's is overall a fairly rare disease. And a lot of it is not about technical expertise, but about an understanding of the pathophysiology and judgment, in addition, of course, to excellent surgical skill. When I first came here, and as I was embarking on the registry, the Fetal Ebstein Anomaly and Tricuspid Valve Dysplasia Registry that I'll mention at the end, I sat down with Dr. Hanjo and several of our colleagues, Dr. Kirsch as well, to think about how we decide what happens for these patients. And of course, it never gets followed to a T, because I think, as Lisa nicely articulated, there are almost is the infinite number of variations we see with the morphology, we also see with the pathophysiology. But I think what's really important is that if we have low right ventricular systolic pressure, and we really think that the RV is not capable, the safest thing to do for those babies to get them out of the hospital alive is the modified Starnes procedure. And I know that Dr. Konstantinov is speaking with us tomorrow. He was the first author of the recent ATS guideline, but I'll just say that, I particularly was thrilled to see that it was adapted into this guideline as well. Be very, very, very wary of those with low right ventricular systolic pressure. They're likely to have circular shunting if there's a patent pulmonary valve, and those children can really be amongst the sickest. So as was mentioned, I think that understanding what's happening in the fetal period first, thinking about fetal therapy and management, thinking carefully and cautiously about your perinatal delivery planning, and then everything that happens beyond that is so critical. And so we've started this registry, and it's to look at all of these different factors that influence outcome, as well as neurodevelopment, is one of the goals of our study. And we are lucky to have many collaborators, 41 sites on 4 continents. I can tell you that I just did a very preliminary analysis of the first 50, this is all prospective enrollment, first 50 patients enrolled, and the neonatal mortality is about 20%. So it's a little better than it was from when we published 10 years ago, but still fairly high when we think about how to manage this disease. And so to conclude, I just want to say that the management of Ebstein anomaly and tricuspid valve dysplasia really begins with the fetus. I get calls all the time about asking about NSAID therapy for this indication. And of course, I love talking about it and sharing and offering that expertise. But what I always emphasize is fetal therapy, as exciting as it can be and as satisfying as it can be, is of course not the end goal itself, but it's just the beginning of pathophysiology-driven, multidisciplinary, comprehensive care. So even if you're able to manage the fetus, you have to make sure that the rest of your congenital heart surgery team, your intensivists, your surgeons, everyone is on board for understanding, thinking critically about the pathophysiology and getting through the neonatal course. So with that, I'll conclude and happy to take any questions.
Yes, we have a question from Dr. Hornberger. Please go ahead.
Yeah. So Lindsay, wonderful talk. Question to you, how often do you present then at your CV surgical conference, your fetal cases? Which cases do you specifically present? And is that helpful in terms of everyone being on the same page?
So I think what we do is for what we've done for the most severe cases. What's interesting is that coincidentally, our cardiovascular surgical conference and the MFM conference are at the same time at two different hospitals. And so what we've typically done with very severe cases where we need a lot of coordination, delivery planning on both sides of the street, at the Women's Hospital, Mount Sinai Hospital across the street, and here at SickKids, is we've organized separate multidisciplinary meetings and invited all of our surgeons, intensivists, MFMs, cardiologists, and such. Although it certainly could be, depending on the particular dynamics of the institution, a very worthwhile thing to just routinely be presenting some of these patients so that everyone is aware that you've got a risky patient coming down the pipeline.
A patient with circular shunt, obviously we're on backup, either OR ready or ECMO ready at the Sinai.
We would. We don't take any chances, but we've always been presenting the ones that we're really quite concerned about, so that everyone is aware and we're already thinking about it rather than having the baby deliver whenever and then really taking days for people to make decisions when you might not have days and you have a kid who gets sicker. So.
Sometimes you have minutes to decide after the baby is born. For instance, I heard about a case that was born with reasonable O2 saturation, but then deteriorated and the O2 saturation became low. So this would be a case to intervene, and that has to be done right away if you want to save the baby. Otherwise, he'll die in minutes or hours. So have to be very aggressive if you want to save those type of babies. But one concern about the anti-inflammatory drug is about the toxicity of it. Can you say a little bit more about?
Yeah, so it's an excellent question. So one of the things that we worry about with NSAIDs is that they could cause acute fetal renal dysfunction, which will manifest as oligohydramnios. And certain patients have also presented with postnatal renal dysfunction. Now, it's difficult to know because we're treating the sickest patients. We certainly wouldn't expect to see oligohydramnios in one of these types of fetuses without NSAIDs. The postnatal renal dysfunction tends to be harder to figure out because of course, you have a critically ill baby who may have suffered from low cardiac output and other things. But it is one of the rationales behind conducting this as a registry and why we're encouraging any sites that are using NSAIDs to participate in the registry so that we really can get more information about how often these things are happening and to gain insights along the way as to how to best and most safely use these types of drugs. So I would say that it's, and there are the toxicities on the one hand, which certainly we need to be cognizant of and manage. But on the other hand, usually we're only using NSAIDs in those fetuses that we think are very unlikely to survive anyways. And so when you think about the relative risk benefit analysis here, you're talking about, you know, maybe even if there were renal damage, at least you would have a live-born baby.
Yes, go ahead.
Not the only reason why the patient's demise. But, you know, I will say that when I was a fellow and I was just learning about how often fetuses with Ebstein's demise and talking to a lot of folks, a lot of what I was hearing was that, well, a lot of them probably get sudden arrhythmias. And one of the really important, and of course, I presented a patient who happened to have an arrhythmia, but one of the really interesting things in our multi-center series was that very few patients had fetal arrhythmias. It was like less than 5%. And so then that's really actually how we said, okay, well, we know, so that's not the reason why we have an almost 20% demise. So what else really stood out to us? We didn't necessarily go in, or at least I didn't. I was certainly only a senior fellow at the time and didn't understand the pathophysiology super well. But when we went ahead and did our multivariate analysis, looking like just in general, really with an open mind as to what it was, that's when we really saw that PR came out significantly in a couple of different models that we used. And that's really what enabled us to then say, okay, it's not going to be the explanation for every single fetal demise and every single case, but it seems to be a substantial contributor to a number of cases. And again, just like you said, Lisa, that's something that we can potentially modify. And that's where it becomes attractive. And it's not with some complex, minimally invasive catheter-based intervention that can only be offered at a few centers of excellence. It's a over-the-counter medication that, if done carefully and closely monitored, can be applied. That being said, I do get calls, not infrequently, from folks that are interested and they want to hear about it. And one of the things that I start to talk about with them before we start to talk about dosing and how I monitor those patients is, what's your plan after birth? Because when I get called from, you know, patients that are in the middle of nowhere, or they're very remote, or from a large surgical center of expertise, and with that comes, of course, your intensivist and everything else, I say, well, it's not ethical in my mind to start giving fetal therapy unless you have a continuation of aggressive postnatal care. And so that's the one downside to this fetal therapy being, in theory, readily available. And so even before I started to embark on those discussions, I said, what do your surgeons know about this case? Are they prepared to interrupt that that circular shunt immediately, whether that's just doing an MPA ligation as an initial stabilization and a later STARNS, whether that's because these patients are going to be really sick. And it doesn't make sense to put a mom and baby through fetal therapy if you don't have the next steps in pathophysiologically based comprehensive care planned.
I saw that we have 2 more questions. We'll just take those 2, and after that, please hold the rest till the end, and we'll have more time for discussion. Yes, please go ahead.
I was just interested, Dr. if there were any thoughts about mechanisms for non-responders.
It's a really excellent question, and in fact, we see this in our NICU babies as well, where we oftentimes try to close the ducts with NSAIDs, and it doesn't work in a fraction of them. I certainly am not an expert myself, although there are a lot of people that have looked into that mechanistically, and to emulate what our neonatology colleagues do, where if they have NSAID failure, they'll often go to acetaminophen. So acetaminophen at very high doses can also cause fetal ductal constriction. And so I have tried it in my non-responders without success. So the short version is that I personally don't really know and have tried to use other therapies, but without success. And the ones that don't respond are typically earlier in gestation. And so I think that there is a factor there that's related to the relative maturity of the endothelium and its ability to respond to cyclooxygenase inhibition.
Thank you. One last question.
Yeah, it's a really good question, Marcelo. I think so. I'm aware of 2 different groups, one in the United States and one in Europe, although none of it's published data. It's just informal anecdotes that I hear from colleagues at meetings that have tried actually to put coils in the right atrium to affect almost like that same kind of physiology with right ventricular exclusion. But the fact that neither have been published makes me think that they didn't end up working. But it is certainly something that people have postulated about, including us. But it seems that it would be a very tricky thing. I don't know if the De Silvas have heard about anything else, but I just want to also point out one thing for this population. The reason to do the NSAIDs is not necessarily to make them biventricular. It's just to get them to survive. We have to be comfortable understanding that a live single ventricle baby, if that is aligned with the family's values and hopes and expectations, is a very, very acceptable outcome.
Thank you very much, Lindsay, for that wonderful talk. We'll move on now to our next speaker. I'm very happy to introduce Dr. Roxanne Kirsch. Dr. Kirsch joined the Hospital for Sick Children in 2016 and is co-appointed to the Department of Critical Care Medicine within the Division of Cardiac Critical Care, as well as the Department of Bioethics. In June 2023, Dr. Kirsch was appointed Division Chief of Cardiac Critical Care, having served as interim chief since January 2022. She is also Associate Chief of Perioperative Services for Equity, Diversity, Inclusiveness, Wellness, and Faculty Development. Dr. Kirsch's academic work focuses on the ethical and social challenges of stopping advanced technologic therapies and end-of-life care, introduction of innovative therapies, and resource allocation and prioritization. Additionally, she works to educate clinicians and enhance their facility with ethical issues intended to pediatric critical care and cardiology to improve patient care delivery, and she makes us better for it. So let's welcome Dr. Kirsch.
Thank you. Just Susan. I know it's uploaded. I just don't know where to find it. Is it on the desktop? Thank you, Lindsay. see, much like life, what would I do without Lindsay? And okay, and can we confirm we're projecting online? That's all sorted? I can assume yes. Somebody run at me if not. So thank you so much for the invitation. And before I even want to get started, it is a pleasure and a delight to be talking about cardiac pathophysiology and not ethics for a moment. As much as I love talking about ethics, I don't get as many talks about my clinical love in cardiac ICU. So it's really a pleasure. Ebstein is actually one of my favorite lesions to take care of as an intensivist because I think of the range of unpredictability about it. It's just always fascinating and always interesting to dive into. I don't have any relevant disclosures. I am an intensivist and I'm Roxanne. So I'm going to take a little bit different angle than maybe some of the talks that you might be expecting, and then leave us open to questions for exactly where you might want to go with all of this. We've seen a lot of the things that I could talk about have already happened this morning, which I anticipated. So once you've had your master's class in pathophysiology from Dr. Hornberger and all the information about fetal Ebstein from Lindsay or from Dr. Freud, then I'm left with very few things to talk about except how you try and navigate the circling the drain. So to me, I'm going to take a few big bucket items so that we can kind of tailor how I approach this across the range in the ICU. But when you look at Ebstein from the intensivist view, you're either like, this baby is super stable, which is not our forte. We're like kind of bored as soon as a baby's super stable, or holy man, this kid is really super sick. But I will point out that the ones in which everybody's got their eyeballs bugging out, including the intensivists, also have a little secret thought bubble beside Roxanne, which is like, woohoo, this is my favorite day because this is what I love to do. And this is where all the nuances of how you integrate all the multiple streams of information to try and figure out your patient in lifetime come to play. And that's what I really love about it, is because it's always changing. So trying to talk about things in a simple way at a certain sense, you got a big heart, you got little lungs. And actually, we haven't talked about the lungs a lot, but the lungs will come into play when you're trying to figure things out in the ICU, particularly as you lead into the more severe aspect. And that wall-to-wall heart, I agree with Dr. Hornberger. I hear a whole lot about it and I care very little. Like the chest x-ray is the least impressive piece of information I can get about my patient because they often don't care. So it's really about how many symptoms they're having and what needs to happen. Obviously, in the moderate range, I tend to class them just trying to think through the very simplest way of what are the things I'm focusing on, pulmonary blood flow problems. I put in this little quotes about syncopated jazz only because that's how I often describe it to my fellows, because when they do have arrhythmias, they love to have arrhythmias. They're likely to be more sick, so moderately sick. But it is not the most common thing in my neonatal phase of patients that I'm generally dealing with is arrhythmias, particularly probably because of where they're being monitored. Postoperatively, more often, every once in a while, we spend more time with the arrhythmias. Interestingly, I either spend time with arrhythmias or I spend time with the other pathophysiology, shunts and pulmonary blood flow. Generally not both at the same time, thankfully. And then of course, once you're into pulmonary blood flow problems combined with systemic blood flow problems, there's many terms you could use. We're just going to stick with oh dear. So this is where we get into the most severe, most intensive part of care. And the one thing I thought was worthwhile just thinking through in a broad sense, if you're in the mild disease category, you might not need me in the cardiac ICU at sick kids. You could be in other places for appropriate monitoring, but that's going to depend a little bit still on exactly how you present and who has what knowledge base where you're presenting. So you're going to need cardiology support no matter where you're placing this baby so that you can understand how much cyanosis is okay. You need somebody that can deal with respiratory distress appropriately. And then you can kind of choose your level of monitoring. By the time you're into the moderate disease ranges, I think you need a very well-monitored environment, but you also need people who have expertise to adjust to changing physiology, because none of these things wind up being static. And so how you alter your monitoring and be able to mobilize a team becomes really important. And once you hit your severe spectrum, then you're anything from you absolutely need a very intense high-level environment. And then some of what we started tapping into was how much planning can you do pre-birth to be ready for all eventualities? And this is where we're talking about a circular shunt and lung hypoplasia and potentially ECMO. So to break this down a little bit, whilst I'm often a bit bored, to be honest, on mild not many symptoms, you got to be ready because you still can't always know exactly what you're going to get when the baby delivers and transitions. So and often these are the kinds of phone calls where sometimes they're not diagnosed. So these are often the phone calls I get, which are the heart is wall to wall, which the only helpful thing is I might be thinking Ebstein. And then how much cyanosis, and maybe they have a murmur, and you kind of think through what they might need, and you can figure out what level of monitoring. Wouldn't necessarily start prostaglandins depending on how the child is presenting. But these are ones where I'm sort of assuming you have some TR and you have antegrade pulmonary blood flow and you're going to be in a more stable scenario. So I'm not going to talk about those further. I took this from our JCTVS techniques, and this is in our Sick Kids manual. Lindsay's algorithm is maybe a easier one to follow, but this is the normal delivery, some observation. Let's see them off prostaglandins. You have some time. So without further ado on that one, let's move into the moderate management. Here's where Roxanne's getting a little more excited and interested. Here's where I'm having patients who might have functional pulmonary atresia. Maybe they don't have significant PR. We can be off be off prostaglandin, or sorry, we're on prostaglandins. You have to make decisions about nitric, but I also agree, I don't necessarily rapidly mobilize to drop pulmonary vascular resistance because you're usually going to wind up running the other direction. So this is where I think the nuanced management and very careful monitoring requires you to be patient. And that can be hard unless you actually understand all the streams of information coming in. So unless you have a good understanding of the pathophysiology, the anatomical components of that baby, what does this echo actually already tell me about this patient, you're not going to be as adept at knowing what to fit in. And what I found interesting is in almost every algorithm review paper of management, it just says intubate, PGE, INO in a box, and that's the ICU management, which is always a little bit hilarious. And I won't go into too many of the pieces, but those things are actually very nuanced and deciding what makes the most sense at the time, because all of those things will impact your physiology and will have negative side effects depending on what's happening. And when I say changing physiology, this can be really rapid. So you don't need to be in a circular shunt necessarily to get into trouble. Because if you drop your PVR a lot, you have a big wide open duct, and suddenly you have no systemic flow. You get a big systemic steal phenomenon. I tend to avoid the word pulmonary over circulation because I actually don't generally care that they have high pulmonary blood flow. What I care about is how much systemic steal is happening, because that's what's getting my patient into trouble. So you have to be able to mobilize quickly. You have to alter your treatment. A lot of these patients, I'm a little bit on prostans, off prostans, maybe go back on them again. There's sometimes, depending on the anatomy that we're dealing with, things that you might want to maneuver. And then you have to consider that some of these patients are premature and could have lung compliance issues. And I find that the more premature they are, the least predictable they are with how they deal with their PVR. So they might have it high, but they can drop it faster than usual. They don't like to follow usual curves. And I think some of our evolving knowledge on lung hypoplasia, this applies to the moderate and the severe categories of patients, is how long to wait on ventilation for those lungs to grow, because you can get some lung growth, especially once you've dealt with the cardiac physiology, and not to necessarily feel like the course can no longer be altered because they're still on a ventilator. This is usually weeks later. You've addressed the cardiac physiology. You have them in the best cardiac hemodynamics you can get, let's say. Usually it's not a straightforward course to get there, but now, gosh, you can't get them separate from the ventilator. In most instances, sometimes you have lung hypoplasia and you cannot manage it. That usually the intensivist should know about that pretty quickly on, because it's very obvious when you can't ventilate them. It's not just an oxygenation problem. And remember that oxygenation or SATs aren't going to tell you everything because you have shunts involved. But ventilation you can usually do. So if you can still ventilate them and you're not on wildly crazy ventilator settings, you can usually get through the course of therapy. And I like to give them time. And across the course of my career, I tend to lean into giving them a little bit longer time. And it's usually in that several week mark when everybody's like, we either need a tracheostomy or to stop altogether, that I'm like, I wonder if we should just wait just a hair longer, because it's somewhere is crossing in, and we need to study this. So as a field, we have understudied this in cardiac critical care. But exactly when they cross the phase into, you have this week where you're like, we give up, 3 weeks later, we haven't changed event settings. And another couple of weeks later, all of a sudden they're weaning and then they're on positive pressure and they're on positive pressure for weeks. So this can be a really judgment-based, difficult to understand and something worthy of more study. I won't harp on about lung hypoplasia. I realize it's a cardiac conference and that was an awful lot about the lungs, but I think it's a very important piece that you have to put together into the whole management. The other thing I wanted to point out, so I didn't have opportunity, I wasn't clever enough to think of this ahead of time, to have an actual trend line on an actual patient with Ebstein. So forgive me, this is just a single ventricle patient. But the point of showing you this is some of our T3 monitors, but you could use any monitoring system. But we have a series here where I'm trying to look at heart rate sats, mixed venous sats, all the pressures, end titles. I also can overlay this with all the ventilator settings and pressures. I also overlay this with a clinical exam. I also overlay this with what's happening on the echo. And those are the streams of information you're actually trying to simultaneously put together. And we never show pictures of the clinical exam because what am I supposed to show you in the ICU except a bunch of lines and tubes? But you have to lay your hands on your patient as an intensivist to make all of these numbers make sense. So I think by the time you're in a moderate to severe disease, you need to be able to do this kind of physiologic trend monitoring. I also think that, of course, there's a paucity of data in ICU related research specific to treating this disease. You're following the pathophysiology, you're adjusting moment to moment. But as we understand these physiologic trends, I think the next round of big data and how we're understanding physiologic trends may start giving us some predictors. And how you put all these pieces together to help predict your timing of decisions, even if it doesn't dictate your decision, could be very helpful and important, especially because we're talking about a rare incidence of a rare thing that happens rarely. Like you're in such small degrees of patients that's really hard to understand, which is why you have to come back to visiting and revisiting. What do these numbers mean in this context with this clinical exam in this patient, knowing what you know about their echo anatomy and pathophysiology? So what I'm really going for in a moderate disease is I'm just buying some time because I need some time for this baby to finish transitioning. I need some time for the PVR to fall. I need to understand if they're getting into systemic steal because of the things I'm doing or because of things I need to do, like taking the duct to keep them out of systemic steal. I need to follow that the forward flow is improving. I'm assuming this is a high RV pressure patient. In a high RV pressure patient, every once in a while, perhaps we might do a ductal stent. I'm going to leave that to conversations that will happen across the rest of the next 2 days. And we talked about the need for ductal ligation. And of course, again, I'm talking about a high RV pressure generating good forward flow. So I'm expecting antegrade flow in this patient. So there's a few, and this one gives you more time. This patient's a bit more stable. You need to be patient and you need to allow your patient to work through these different parameters so that you can decide what the best management strategy is. So we're sort of in this part of the algorithm where you're unstable, but you can be stabilized, possibly to a large degree. Probably you're going to be thinking a lot about the duct and then figuring out what opportunities you have for moving forward. And then we'll go into severe disease. So this is where Roxanne's thought bubble is celebrating, although in the moment I probably look more like a firefighter with a whole bunch of octopus arms happening and it all kind of is going on at once. So the more you can prepare in advance, the better. The more you are in a center that has readiness to actually be able to rapidly mobilize systems, discussions, and understanding of what to do is critical. And all your patients are going to look like the little one in the picture. You're going to have a whole lot of drips and a whole little tiny patient, and you have to figure out what you're doing in the long term. Here is where I don't think you're going to have a lot of sorting out about lung hypoplasia right now. You're in a circular shunt, you're in a cardiac scenario in which you don't have time. So of course I expected this, but all my thunder is stolen because we already talked about circular shunt not once, but thrice. But you can never talk about a circular shunt too much because it is the most interesting part. This is my favorite picture of a circular shunt because when I'm trying to teach this to the fellows at the bedside, it usually involves a lot of hand waving and somebody's trying to be the red blood cell traveling about theoretically through the heart. And it's not actually a circle. So in all things cardiology, we love to call it a simple circle, but it's like a figure 8, but that doesn't roll off the tongue. So it's really trying to understand this piece of it. But then more importantly, when you're at the bedside managing, it's this piece of it. I have systemic steal with no effective systemic blood flow, but I actually also have a high degree of ineffective pulmonary blood flow. Like we are not having anything good happening. And I think that this is probably the best version of what my face probably looks like in most of these scenarios, because you're in a bit of a like, okay, like we have to do something rapid, but what exactly is the best move to make in this moment in time? And how far can I medically stabilize with a few extra decisions happening? The one thing I wanted to point out here is you're in this part of the algorithm, and one of my principles in life is to try not to medically manage something that needs a surgical blade. So you need to be communicating with your surgeon about what you're doing and how you're getting there fast, because fooling around is going down the drain. So you need to be able to mobilize fast and have some good conversations about where you're going and how many tests, studies, monitors you're doing before you get there. You have to be ready for immediate surgical intervention. I think we've done all variations on some of the theme that came up, so we can deliver at sick kids if needed. There's some logistical extra pieces of who's comfortable where from regards to MFMs and obstetricians. We're also across the street, so we have an underground tunnel transport system, so that of course gets taken into consideration. We can supply ECMO at birth, and we can transition from the placenta to the ECMO circuit if we need to. So the multidisciplinary conference in which you figure out what seems to be the best strategy for the fetus and pathophysiology that you have then, and how much opportunity you have to figure that out after, in the minutes after birth, becomes really important conversations. And that's when you want to have everybody to bear. And I actually like, as Lindsay had mentioned, some of our Zoom meetings, they take a long time. Lots of things are logistically chatted out, but unless you literally talk about every detail, who's doing what piece of the puzzle, you can't get these babies through. ECMO, I have not put in several slides on ECMO just because I realize, again, it's a heart conference and we possibly can talk about that at ECMO conferences, but you can rapidly mobilize ECMO support. And the one note I wanted to make is, if you're in a circular shunt, ECMO is not going to solve all your life problems. You need a lot of flow, and you're still going to have to do something about how much steel you have coming down that duct, no matter how you deal with it on ECMO. So ECMO will not solve your life problems. And if you can get the baby's life problems solved without ECMO because you rapidly transition to surgery, even if you need to spend time on ECMO after surgery, this could be a better option for your patient because you'll still reduce the amount of ECMO time. All your organ steal could still be happening. The flow rates that you need are a lot when you have a single ventricle BTT shunt patient with a restricted pulmonary blood flow. When you have ductal flow flying backwards and cannulas rates running at hundreds of mils per minute, you may not be able to overcome and adequately systemically perfuse your patient. So ECMO always seems like a fabulous, like throw it on and everything's solved, and it will not be. So you need to consider this. And then we hit this interesting yeah moment, because I think there's like only somebody who's done a lot of circular shunts does the like, is it a less severe circular shunt or a more severe circular shunt? But this is where experience comes into play, and there's a whole lot of nuance of how many maneuvers can I make to try and actually maximize systemic flow, minimize the circular shunt, get us to ineffective blood volume circulations that are low enough, the ineffective percentages are low enough that I actually have a baby that I can sustain for some period of time to allow some changes to be made. And some of these patients, I have done ones where we're off prostaglandin, we let the duct restrict, but they still need pulmonary blood flow, so you open it back up. This is where I would not be using NSAIDs because I want to be able to potentially manipulate that duct. This is where you have to accept this is a bit dicey because I can't always guarantee I can get the duct reopened and closed again. And if you're doing that a couple of times, I call it the fool around. So there's no point fooling around. Ask for the surgical blade. You need to commit and make a decision to move the patient forward. So here in severe disease, my management goals are largely stabilize to prevent death. All I'm trying to do is get the baby not to die for a long enough period of time that we can figure out exactly what pieces of the puzzle are there. And why I say lung hypoplasia in this moment is this is where you want to try and at least understand, are these really lungs that you are never going to recover? If you have the opportunity to understand that or really feel like that's not going to be the case, it may not be appropriate to continue with other palliative strategies. I think this is an area that we need to develop more. The CDH population, so the congenital diaphragm population, has lots of looks at lung hypoplasia. I'm sure Lindsay knows more about this than I do. At present, my PICU colleagues spend a lot of time looking at these things, but we probably would benefit from seeing if we can find some predictive models for how much that impacts, because it's really difficult once you've gone through the cardiac palliation to then realize you have lungs that are never going to function. You want to try and minimize your impact to the end organs because, of course, you're going to recover from anything that you do better with good end organ function and without multi-organ dysfunction, including the seizures and neurologic detriments that happen. And then your timing for surgical intervention, which, as Lindsay had pointed out, we would go to the RV exclusion. And I'm going to leave it for all the delightful surgical conversations that are to come at this conference, because I just enjoy how much of a deep dive we get to take on each topic. But just to throw in why I love my job quite as much as I do is you take all of that and that's really difficult. But then you throw in a flavor of this and a flavor of that, and you get into these scenarios where this is like live time. I love that we published this case because the memory holds strong, and it's like Osami and I, Dr. Honjo and I, sitting at a bedside. This is the 12-hour, Roxanne's really glad she buys very sturdy shoes for on-call, moment to moment. How do we intervene on this patient's physiology because it keeps changing? And so we have somebody who had circular shunt, which got addressed, but they're premature. So we also had RDS. We give surfactants, suddenly your lung compliance changes. Suddenly we have no systemic output, but it's not actually the circular shunt anymore. But now we still don't actually have adequate systemic output, even though we've minimized the circular shunt. We added some PA bands. This baby is like 1.5 kilos, if I recollect. So going to a 3.5 BTT shunt was not going to actually necessarily solve my problem. We put on PA bands at the bedside. Okay, we're out of high pulmonary blood flow. We should have good systemic perfusion. Why isn't this working? And we still wound up not having adequate fill to the left ventricle to be able to maximize cardiac output, and went on to do a modified Starnes in the fact that we did the rest of the RV exclusion, but left the PA bands and the duct open just because that seemed like our best way to control pulmonary blood flow at the time. So it was one of these really interesting collaborative moments in which you have to really work together as a team, because no one person can kind of figure that piece out ahead of time or in the moment. We're going to talk a lot about outcomes. I mean, I threw them up here because I think it's important that the intensivist has to have a very deep understanding of what we're doing and what we're suggesting should be done as to what we might accomplish, because we're also highly involved in counseling the families. But I'm going to let everybody duke it out as to how we're doing our options and talk about that more in depth. And this, I just wanted to point out because this is the multidisciplinary collaborative team. At this extreme gymnastics, as I call it, when you're doing cardiac physiology gymnastics, you need everybody. So people who can come, give dedicated time together to look at all the streams of information to make a very measured decision about the patient so that you can counsel appropriately and move forward. But you can't just do that across like a leisurely 3 days or a 2-day symposium. You got to do that and mobilize in like 15 minutes and have a chat that's going to last 30 minutes and move. And you're already mobilizing teams as you go. So I think that bringing our teams to a very collaborative, respectful, expert place is critical actually to how we improve outcomes for these patients. So we know there's a range of outcomes. You know your intensivist is going to get most excited about moderate to severe disease, but don't worry, we still feel deeply about paying proper attention when it's less exciting, just in case it becomes exciting. And a lot of it is making sure that the intensivist understands the pathophysiology enough that we can adapt to changes in pulmonary blood flow states and why that might be happening. You have to have an understanding of what may be impacting what. This isn't going to be algorithmic care. I don't think we're ever going to get this to algorithmic care. It's all about adapting to the physiology in live time and rapidly being able to change what you're doing. You can't commit and walk away for 12 hours. You've got to commit and follow up, commit and follow up. I'm happy to take questions. Thank you so much for your time and attention.
Thank you very much, Roxanne. That was fabulous. So yes, we'll open it up to questions and comments, and I'll just kindly remind everyone to please use the mic nearest to them when asking a question.
Thank you, Roxanne. That was an excellent presentation. One of the most challenging situations that arose for us, and actually another center was having the same challenge recently that I heard about, is it was a fetus with circular shunting, wasn't responding to ductal constriction, and was hydropic. So how, and then from what I understand is there's a lot of consternation about taking those patients that are hydropic immediately for cardiac surgery on bypass, but yet they have a circular shunt that often needs to be interrupted. So how do you kind of balance that situation at the bedside in the ICU and with the surgical teams?
I think it's a great question, Lindsay. And I think you have to start a little bit from a philosophic standpoint, meaning that are you in the push the envelope, expert abilities, teams that can come together, and also can accept that this may be on the edge of what is possible, counsel appropriately so that you actually have a family who is on board and actually understands what that means. This is possible, but likely won't work, so that you can kind of proceed to say, here's the things we can do to try and optimize either our understanding of whether this is not a case that can be rescued, or our understanding of the timelines we need to establish that this case can be rescued. You probably have to commit to doing something surgical to interrupt it to be able to move forward, which then always becomes the difficult part of, we've now offered a therapy, we don't necessarily know that it's going to turn out well. It's not necessarily so different from many days of our lives, but it's sort of on the extreme end of that. And so I think that it takes the right dynamic of having the appropriate patient with the appropriate family that understands, with the surgeon who is willing to engage with you on what's the pathophysiology and what, well, we can do things. What do we think we should do because it will accomplish something towards a purpose of understanding if this is going to be a scenario that's remotely survivable, or that we should accept that we cannot rescue at 2025 in the current state of what we know.
So in that situation, would you consider like ECMO and clipping the PDA to and stabilize the patient? Because some patients, they have, like you said, associated comorbidities, and you didn't have time to evaluate everything. Like you can
Agreed.
have
Yeah, I think
gut
that's what I mean
problems.
by commit. I think you're stuck. And I probably would choose ECMO and take out the duct. I mean, I might make some of those decisions based on the size of the patient and what we think could happen. Whether you're on ECMO or on bypass, realizing those are different modalities, but you're still having an impact to the patient overall. Not choosing to do those will leave you in end organ dysfunction and a spiraling situation. Choosing to do those might make for complicated recovery, but you'll be recovering in a better pathophysiology. So also having said that, I have always had a bent towards a more aggressive possible choice, because I like to recover in the best cardiac pathophysiology you can do, even if it's a long, hard couple of days or weeks for the intensive care team, because of all the other things that go along with taking on complex therapies. I just think that even though there's a lot of comorbidities going in, or you might have a lot of comorbidities or organ dysfunctions coming out, you still have a much easier time figuring out what to treat and what to manipulate when you stabilize the cardiac physiology.
And in this situation, if you have high drops and circular shunt, would not consider, like Lisa said, to have the delivery in the OR and the team prepared to go immediately?
I mean, this is one where I would hope that we had a plan in advance and that we'd have agreed on how we're going on ECMO, whether we're transitioning from placenta to ECMO, or whether we're going to take a period of time to intubate the baby and move into the operating room next door. But we need the fetus and mom next door to the cardiac OR, if not in a cardiac OR in this scenario. So to have a plan. The other thing with hydropic patient that I think was helpful and we might want to consider earlier is if you drain the lung effusions in advance and the ascites in advance, that makes it easier to stabilize immediately post-birth. So even if that's not going to make a longer term change, it makes the stabilization easier. So doing that in advance of actually delivering can be helpful.
No, okay, so Mark next, go ahead.
Yeah, it's a question I don't usually ask about teams management, listening to you, Roxanne, and imagining people around the teams. In other lesions where we've struggled to improve morbidity and mortality, such as hyperplastic left heart, we've created a single ventricle team, pulmonary vein stenosis. And I don't know if listening to you, and although there's improvement in outcomes, perhaps as suggested by Lindsay, if it's worthwhile thinking about an Ebstein team, although it may not be practical given, how rare it is and schedules and stuff like that. But it sounds like being familiar with situations, being familiar with each other, knowing each other's decisions may be helpful.
I mean, I think it's a really interesting idea, Mark. There is something that would be lovely if we could have a team associated with almost every lesion because the kind of PhD level knowledge it could be applied. But I would also agree what you pointed out. There's a practicality involved in who can actually attend to it. So I think where the mix of the single ventricle team should have a pretty solid understanding, given that the Starnes RRV exclusion surgery. And at a center like ours, I think it's still reasonable. You've got 3 to 4 surgeons at any given moment in time and a small enough collection of intensivists that people are usually pretty intensely aware of the immediate issues. And the other thing you can do without necessarily creating a team is there is a version of having a team without having a team, which is if you have existing experts in your institution, relying on them, whether they're technically the person on call or the MRP, to just come in and help out or give extra thoughts is, I think, really important. And that's part of maintaining a collaborative center so that we always maximize our group expertise by making sure the people who are spending the most time with that particular disease or pathophysiology are available to you and can help you out.
Other